So thank you. This is, as Dr. Wathme mentioned, this is always a wonderful weekend. We've had alumni conferences intermittently. When I started as chair 12 years ago, we started having them every 2 years, and this is the largest turnout we've had. And as Dr. Wathme mentioned, our department has changed a lot. It's grown a lot. When I started on faculty, I was called faculty number 9 because I was faculty number 9. They called me number 9, and Chen was number 10. And a lot of our attendings called us number 9 and number 10. So we're up to 34 now. And we have exploded as a department. I've been able to recruit some of the most talented surgeons in the country. And this building took 10 years and a lot of blood, sweat, and tears, but it is truly a remarkable place to provide care for patients. And I hope many of you who haven't been here, just talk to a faculty member. We'd be more than happy to give you a quick tour. But all our clinics are here, our office space, education space, which the alumni supported for our residents and fellows. And we have outpatient ORs, therapy, and imaging here as well. So it's a wonderful facility. And when you talk about the best thing about UVA Orthopedics, I can tell you it's not the building. Buildings get old. Someone will build a bigger building. It's the culture we have in this building. It's the people that work in this building. And it's the alumni that laid the foundation for us to be where we are today. Dr. Wong, my chair, this is the Wong conference room. Everyone, residents, the legend himself, the OG is here. And his picture is there. And every time he walked into my house last night, and I broke out into a sweat because I thought about conference. And Todd Milbrandt and Sonny Gill, we all get scared when we said Dr. Wong to this day. So, but no, we wouldn't be here without him. We have a span of residents. Dr. Charlie Johnson is here. He graduated in 1981 and went on to be chief of Texas Scottish Rite in Dallas. And then we have Alyssa Altoff, 2020, four. So we have an incredible range of 40 years of resident classes here. And it's really remarkable. The loyalty from the alumni is just incredible. It's truly remarkable. Just a few quick facts about UVA Orthopedics. We're the highest ranked program at UVA Health for the last 10 plus years. We've grown in 2013, when I took over as chair, we saw 50,000 patients in orthopedics. This year, we will see almost 200,000 patients are going to come through this building. We did 5,000 surgeries in 2013. We did 10,500 last year. We're the busiest surgical service, double general surgery, which is the next busiest surgical service. And what's really remarkable is we have the highest patient satisfactions as a center than all other 93 clinics at UVA Health 3 years in a row. We have the highest team member satisfactions and team member retention. And because the faculty are scared of me, I have the highest faculty satisfaction of all 20 clinical departments. So, but this department is really a remarkable program. It's all because of the shoulders we stand on, and the alumni and our former leaders. And I'm so gracious and grateful that they come back every year. My chief residents are in the room, Insak Yi, Don DeGrange. They scare the hell out of me still. Insak's this tiny little guy, but he's really scary. I'm telling you, watch. But Scott Urch is not a tiny little guy. He is definitely someone you should always be scared of. Played football here at UVA. But and all my junior residents, Sonny Gill, Eric Neff. It's crazy that the span of alumni that are here. But we have a remarkable program because of Winston and Truett Cooper. CME office, my executive, my project manager, Carly Bacher, who you all have met before. She's done a remarkable job for this. So alumni, we have a dinner tonight, and then alumni and faculty, we have that baseball game. I just need to know, I have all the tickets, so I have to send you the tickets to yourself. So please let them know out front if you're coming. And also dinner, we need to know. Spouses are invited, alumni, faculty, please bring your spouse or significant other. Dr. White showed up. Indian Standard Time, late as always. Dave, so the two people who are not here are the ones who, I am the boss. Jason Oliviero and Eric Dorff, who are not here this morning, Eric, you made me. I couldn't get him to leave my house. I think there were like 100 people at one. There was 100 people at my house at one point. You couldn't walk, but it was wonderful to see everyone last night. And thank you for coming. All right,
let's get the show on the road. Spine is up first. Dr. Frank Shen. Let's go.
So I'm going to take a few seconds just to, and I'm going to get credit back, Winston, for the time on us. But I will reiterate what Bobby said about how great it is to see everybody here. And when I was a resident, my junior residents, and then my chiefs, and how much we learned from them and how much we passed on. I would be remiss without mentioning Dr. Wong, who gave me the opportunity to be a resident here in this room and everything he's done for me. I'd be remiss without mentioning Dr. Abel, who took me under his wing and taught me how to do pediatric scoliosis better, and remiss without Dr. Miller, who is continuing in retirement to give me opportunities. And of course, Dr. Whitehill, who you'll see a little bit of his influence in my talk. What I wanted to do is just give you real quick, where's the advanced one on this? Here it is. Just our division, which has changed over the years from when I started. Got the point down here? Yeah. There we go. I'm after Dr. Stamp, who was one of our former chairs. I'm the Warren G. Stamp endowed professor. When I came, there was a lot of change. People retired and left, and Dr. Scheimer, who is my partner, is the single most important person in this division to me. Him and I have been together, 17 years? And we've really changed the focus and the direction of this department. He is, without a doubt, the single most important person in this practice to me. We were able to get back Josh Lee, who's a resident, is an incredible researcher, an incredible surgeon, an incredible leader. He's our fellowship director. And we are exceedingly lucky to have Steve Lockey, who was actually at the CSRS Young Leaders, Emerging Leaders program. So he wanted to be here, but he's going to be the next generation here in the country. So that's our division, but we also have now 4 PAs. So we really can tell how big we've grown, and we have an NP on the floor. I'm going to pass it to Dr. Lee, who's going to give us a little overview about the fellowship and his talk.
Thank you, Dr. Shen. I'm Josh Lee, graduate here 2016. Our spine fellowship started with Dr. Chen in 1994. When I graduated in 2016, Dr. Chen already retired, and he was very kind. He taught me how to do the spine surgery in the cadaver lab. Currently, we have 5 spine faculty, and Dr. Bachman is the pediatric spine surgeon. The rest of us are the adult. We do the cervical spine, we do the disc replacement, we do the corpectomy, posterior foraminotomy, laminoplasty, and occiput to C3 fusion. In the thoracic spine, we do the posterior corpectomy, and also we do the lateral approach, we do the corpectomy. For the lumbar spine, we do the ULBD, which is the unilateral laminotomy with the bilateral decompression. We do the cortical screw fixation. We do O-lift, traditional T-lift, and A-lift. For the deformity, we use a different osteotomy to correct the deformity. And this is on the right side. This is the patient with L4 PSO 3-column osteotomy. We have the fellowship reunion in the 2023. And last year we have a very good fellowship reunion. On the right side, here is the fellow, 2020 current fellow, 2024, 2023, 2022, 2021, 2020. And we have a very short video. We have a party in the Darden School. And after the party, we have the symposium. And we play the pickleball after that party. In the last 3 years, we matched our top candidate. Next year, hopefully, we will get the 2 spine fellow. And we all not only do the education, but also we do research. Currently, we have the 4 clinical trials, and also we do the basic science research. And I just want to give you an example of our clinical research we are doing now, which is on the coin test. We know that most common examination for the cervical myelopathy is a tandem gait. But not everyone feel the tandem gait have the cervical myelopathy. Like this patient with the thoracic stenosis, he feel the tandem gait, but he do not have any cervical stenosis. And this patient have the lumbar stenosis, which altered his proximal thigh muscle weakness. And he feel the tandem gait, but there was no cervical stenosis or the thoracic stenosis. But there are some patients have the tandem stenosis, which have the lumbar stenosis, but on the top of that, also have the cervical stenosis. For this kind of patient, we do not have a good examination for the cervical, for the hand function. We have a grip release test, but that test only evaluate the motor function. We do not have the sensation function test. So for this kind of patient, we do the coin test, which is the 5 coins putting together, and ask the patient to pick up 1 by 1 and make another stack of the coin. For most of the patient without cervical myelopathy, they can finish within 15 seconds. But for some patient with severe myelopathy, you could not do it. Like this patient, he was very frustrated. He could not put all the coins together. And eventually he gave up. So we want to see what's the reason the patient feel the tandem gait, right? Most of patients, yes, it is from the cervical myelopathy, is about 44% of patient, but over majority of the patients do not have the cervical myelopathy. They feel the tandem gait, but they have the different pathology, like from the lumbar spine, old age, minor stroke, severe diabetes, or sensation loss in the bilateral feet. For the patient, feel the tandem gait, but without cervical myelopathy, they all pass the coin test. And this patient, we did the surgery, ACDF, and you can see after surgery, the patient can perform the coin test much better than before the surgery. And although he finished within 26 seconds, it's still abnormal, but he did finish the coin test. So we want to find out how the patient doing coin test before and after surgery. This is a PACU nurse, and she has some problem with the buttoning buttons, picking up the small objects. And you can see this is the X-ray. MRI showed severe stenosis in the C5-6 and the C6-7. And the CT scan showed that there's the earlier signs of the OPLL in the C5-6 and C6-7. So we did the MGOA score was 13 before the surgery. And we did the ACTF C5 to 7. And after surgery, MGOA score improved to the 17. And you can see the coin test is also took her less time to finish the coin test. And for most of patients, after the cervical spine surgery, their MGOA score will improve and their time to finish the coin test will significantly decrease. They also correct the coin test examination also correlate to the MGOA score. And inspired by all these patient recovery, my clinical scribe, make the coin test box for me. And my research coordinator made a coin test board for me. Thank you.
That's great work. It's nice to have Spine first thing in the morning, and it's nice to have you guys as a captive audience, so you can't go anywhere. So I'm going to take it the other way, and Winston told me to make it general, so I'm going to make it as non-general as you can. So the occipital cervical junction is a space that is hard to access, right? And so the question is, how do you deal with things at the 0-1-1-2 junction? So here are 5 cases over the course of the last few years that have made me change the way I think about it. Because on the top left, is this mouse? We have a mouse?
There's no mouse.
No mouse, good. Top left, we have a epidural abscess that's behind the dens and C1, C2. The next one's a hygroma that is at the tip of the dens. The second one is don't worry about you guys can let that go. C2 pannus, and then there's a overwhelming osteomyelitis, and then the bottom right is a fracture dislocation with a pathologic fracture. So traditionally, how do you address 0-1-2 lesions in the front? It's a transoral approach, right? You go through the mouth to get to the body of C2 and the dens. And if you need more extensile exposure, it's a transmandibular approach, and you certainly can extend it down to the high cervical approach. You don't want to do this, and if you have this problem, you don't want to receive this. This is a very morbid procedure. So then the question is, here's a schematic of the 0-1-2 junction. It's a bit daunting because you got the nerves, you got the bones, which are not your normal anatomy that you're used to seeing at 1, 2, 3 in the occiput, and laterally you got the vertebral arteries. So the question I started thinking about is, can I get to the 0-1-2 junction from the posterior aspect? And traditionally, there is a way to do it in other parts of the body, right? So we know in the thoracic spine, you can take a rib out, you can go transpedicular, and you can push the lung out of the way, and you can get the vertebral body. And I can do 2 or 3 level corpectomies and have extensive approach. But it's associated with doing rhizotomies. You take the nerve roots, you take the thoracic nerve roots, and you have a chest cavity, which allows you as much expansion as you want to put in cages to reconstruct it. We know in the lumbar spine, it's a little more challenging. You can do discectomies, you can do biopsies, you can do corpectomies, but how do you reconstruct it? Because the nerve roots tether you and you can't take the nerve roots down there. So in the lumbar spine, I've been able to do it by doing single level corpectomies, by pushing the cages between the roots and flipping them up and expanding them. I can do a 1-level corpectomy. I can certainly do a 2-level corpectomy. So over the course of 20 years, I started thinking, well, what do we do in the cervical spine now? What about this? The bony anatomy is a little different. There's a cervical nerve roots, there's a spinal cord, and there's a vertebral artery. Can I get to the front of the spine from the back? The vertebral artery, interestingly enough, is a little more lateral at V3, right? V2 is within the transverse foramen in the subaxial spine. V3 is when it comes out, and V4 is when it joins and becomes the circle Willis. So if V3 is a little lateral, you get a sense that there's this little portal, if you pull C2 nerve down, where you can go through, where you're medial to the vertebral artery and lateral to the spinal cord. You could probably get to the dens in the vertebral body. But that for me was very possible, but you kind of want to get something a little bit bigger, like this. Because if you can get a little bigger, you can do bigger corpectomies, you can start reconstructing things. But is this a block? Is this a wall that you can't go through? Is this a block? But the nice thing is at C1, 2, and C3 is you can take the roots. We take the root at C1 because we really don't even see it when we make the decision. C2, we can do a rhizotomy, and C3, I don't take it often, but it certainly can. And if you can take those roots, then suddenly this is not a block to the anterior column. So I start thinking about it. It's not a really complex. I just started thinking about zones 1, 2, and 3 in the occiput, and you say, well, that's the occiput. That's zone 0, 1, 2, and 3. It's just your vertebral body. But if you think about the dens, it's C2, but it's really zone 1. It's behind or in front of the C1 ring. So it just changed the way I thought about things. You can do laminectomies of 1 and 2. That gives you access to that. If you needed to get more lateral, the ring of 1 runs into the lateral mass. So that's your lateral block at 1. The lamina of 2 runs into the pedicle. That's your lateral block at C2. And if you need to go higher, you can do a foramen magnum decompression, which is actually not as hard as we think it is. It's just a bony resection and we work around that. And distally, we can go down the lateral mass and the vertebral artery down. So I'm just going to take you through a few cases that kind of came in the order of my practice that changed the way I thought about things. This is the first case, 77-year-old myelopathic progressive cord signal change, multiple falls. You can see in the axial and the sagittal, there's compression not just from the pannus, but also posterior, the ligamentum, and of the bony anatomy. And then this pannus is actually directly posteriorly. It's pushed the spinal cord a little bit more to the right. So that's actually your pannus right here. So while this is anterior, it's come more posteriorly. And this is the first time I started thinking about it. If I do a laminectomy of C1, that tumor, that mass is right there. So this is really a zone 1, zone 2 lesion. If you do a laminectomy, here's the reconstruction. If you do a laminectomy of this ring of C1, you can biopsy that lesion and do the debulking. And so it turned out it's primary amyloidosis, not a tumor, didn't need systemic treatment, didn't need radiation treatment. In 4 years follow-up, when you stabilize it and debulk it, you can see that it's completely resorbed, it's been resected. So then this second case came along, 42-year-old overwhelming sepsis in the MICU. Actually had pus up and down the whole spine, cervical, thoracic, and lumbar spine. But this is the one that was most daunting to take care of, right? This up here is at the zone 1, zone 2 as well. But the difference between this and the last case is that this one is all ventral. It really isn't pushing your spinal cord back. So I can't just do a straight laminectomy and get to it because the spinal cord's in your way. You can't manipulate that. I mean, you can if you want, but I wouldn't recommend it. So then the question is, come more lateral, right? So just come more lateral, scooch around the cord, and you can get to the ventral aspect of the vertebral body at the occiput C1 junction, or C1, C2. And what does that mean? Laminectomy of C1. That's your lateral mass, you come around there. And at C2, you do a pediculectomy, a pedicle resection, and you take the root of C2. I took my first root of C2 with Dr. Whitehill when I was a young attending, and he told me how to access the C1 to C2 junction and do rhizotomies. And so I started building on this and did a pedicle resection and a rhizotomy. And that gives you lateral access at C2, right? So now we can scooch around the front and start to gain access to that area. And then they get a little bit of they have no pedicle, so I did a translaminar screw at C2, lateral mass screw at C1, and a small short occipital fixation. Was in the MICU, got out of the MICU. At a year, I was back at home, and I've just followed him just for fun over the last 7 years. He was doing well. This is his follow-up MRI. No, abscess is gone. This one, starting to scooch up a little higher. Here's the mass. It's a hygroma. It's a cystic filled fluid. Looks cystic. It's probably not a tumor. But this one, again, is not straight posterior, and it's even more lateral, so it's even harder to get to. This is actually the dens tip right here, and this is the lateral mass, and this is the spinal cord, and that's the hygroma. It's a little bit off to the right, and he's myelopathic and getting weaker. And so this is an occiput zone O and zone 1, so it's even higher. I need to get up higher than just simply doing a laminectomy of 1 and doing a laminectomy of 2. So what's blocking me, right? If you do your laminectomy, what's blocking you is this piece of bone, which is the lateral mass. Well, if the lateral mass is in your way, what do? Well, you just burr it out. So I took my C1 screw and I took a burr and burred the medial part of the lateral mass out. And that gives me access to sweep around the dens and around the spinal cord in order for me to biopsy and aspirate it. And so this is the pre-op right here. There's still a little bit of the hygroma left, but between the decompression and the aspiration and debulking, I was able to give the cord more room. I think as I get further, I'll be able to do a better job with that. These, as they get higher, are a little bit tougher. This is an 83-year-old who has osteomyelitis, had 6 weeks of IV antibiotics, got worse, increasing headaches, mental status change, was on a medicine service. They did a lumbar puncture, a gram-positive coccyx, said, you really need to get source control. Can you get to that? 83-year-old, I don't want to do transoral, right? So same thing, I've already done several of these over time. This is a little bit more left-sided. It's up at the tip of the dens. It's probably in the foramen magnum. So really how to get up in there from the back. Same thing now, right? This is O zone 1, zone 0. So pediculectomy, rhizotomy, laminectomy. And you can see now the opening, there's a back pushing curette that gives me access now. I can get there into the back of the dens. and a pituitary, so I can get a back pushing curette and push that down, and I can get a pituitary in there and actually take and resect the dens from the back and get up as high as I need to. Maybe not as high as I need to, but at least up to the tip of the dens on the ring of C1. There's the fixation. And so the post-op, you can see that that's my laminectomy, transpediculectomy, rhizotomy. The dens is gone here, the dens is gone there, dens and part of the body is gone. This is the, I had a follow-up MR, that's the follow-up MR and CT. This is the last case that sort of is the challenge that helps you understand how do you reconstruct it. So all 4 of those cases were debulking and decompressions, right? So make the window big enough, you can see it. And I think the current fellow was with me and can tell you that you can actually see the anterior column pretty well from posteriorly, but the problem is just because you can see it, you can't reconstruct it that easily. So in this particular case, we just did probably about a month and a half ago, was an 80-year-old who had increasing falls and had this pathologic fracture dislocation of C2. Here's the CT scan. In this particular one, the dens is intact, which is actually very helpful for me. So when I saw that the dens is intact and this is a pure body, this is a zone 2. I actually don't need to work too much higher. All my access is not about the debulking, it's about trying to get an anterior column. You certainly could go occiput to C5 and do no anterior column support, and I think that's reasonable, but I've been trying to get away from occipital fixation because it's very morbid. But if I'm not gonna go to the occiput, I really need to do anterior column support. That means putting something in the front, and that's the technical challenging part. So I did a wider resection in order to do that. Here's an MRI of that. So he gets the fixation from C1 to C4. That's the Woodson sitting in the back of the dens. This marks my level. And again, back pushing curettes, push into the body. Resection of that. So when I went to reconstruct it, I cut a fibular graft. That's right there. You turn it 90 degrees, you sneak it around the spinal cord and the vertebral artery. I put a nerve hook on it, and I flip it up, and I put a back pushing curette on, and I turned it upright, and then I compressed down on it. So that's my anterior reconstruction for C2 from posteriorly. There's the CT scan. I didn't do a very good job doing my carpentry, so I apologize to Dr. Wong and all my mentors. I'll try to do a better job cutting that more flush. With C3, I think I seated it centrally. I probably could have did a little better work on the contralateral side. It can open up both sides in the future if I get a little bit better at this. And then seated on the C3 body. And then I did a posterior wiring. One of the funny things is I can put pedicle screws in, but to watch Dr. Abel and the other older surgeons put in wires you don't realize how good they are at putting wires. So I did a modified galley, and that took me longer than most of the rest of the cases, just wiring the C1-2 right here. But I was pretty happy with the eventual wiring. And so I put a structural graft in front and a structural graft in back. So all things old are new again. Putting in hooks and wires is what your resident, you learn to do. And now none of the residents and fellows now to put in hooks and wires. So I think there's always something to be said about the technology, the techniques that we did before. So what's next, right? What do we do next? The OC junction, I think I know I can access it. I think if it's a zone 2, I can reconstruct it. And I talk about this zone right here to get this window. But here's the thing I didn't talk about, I alluded to a little bit, is the vertebral artery is in your way, right? Zone 3, zone 2, V2, V3 is right tethered at this foramen where C2 comes out. But I started thinking, if I can figure out a way to deal with that, I probably can get down further. So I have one case where I did do a vertebral artery translocation and took it out of the transverse foramen for a tumor. But if you do a translocation of the vertebral artery and you take out the pedicle of 2 and the pedicle of 3, you do a rhizotomy of 2, a rhizotomy of 3, you get an unparalleled access to the anterior column. You can get in there and take the disc of 2, 3 out and the body of 3 out and the body of 2 out, and you can reconstruct that from the back. So I think this really is the next step for me. I think it has to be done in the right patient, but I do think it's very feasible. Not just feasible, it is possible. These are technically challenging cases. I think rhizotomy, if you do that, it'll give you access for a biopsy. If you want to do a debulking, you should do some bony work. And if you want to reconstruct it, I think you got to learn how to manage that vertebral artery. Thank you. 41.
Spine, Frank, not bad.
41.
Practice changing. I never fix the occiput. I mean, that's, but thank you for the fibula and all that. That's a terrifying talk. I'm glad you're here. I'm glad you're here.
What's the occiput of the hip?
I don't know. So anyhow, that was great. Spine gets extra credit for staying on time, actually being ahead of time. So good job, Spine. Normally Frank's operating around 2 o'clock in the morning. So 8 o'clock, he knows what he's supposed to do. The next group up is going to be the pediatrics group. This is Dr. Mark Romness and Keith Block will be talking to. So thank you, Mark, for giving stuff. And before we start, Pete, one person we haven't thanked yet, I just want to say thank you to is Jalen Gregory in the back. He's our IT guy. He's going to be running the entire show today. So thank you so much, Jalen, for doing this. Okay.
Well, thanks, welcome. I really appreciate everybody coming back. It's a great weekend already. So just to introduce you to our division, which is the down button.
I feel better now.
Yeah. So our division, currently we have 3 physicians and 1 PA in our group. There's Dr. Bachman and me, who are the 2 surgeons. We also have Dr. Lather, who's non-operative. She started as a pediatrician. We trained her how to do orthopedics, so now she's an excellent source for pediatric orthopedic type stuff, especially for some of our metabolic stuff. She's been awesome for that. And then our PA is Emily Feiner. We trained her fresh out of PA school. And so she's one of the best clubfoot casters in the state of Virginia and probably the East Coast. She takes these unbelievably difficult feet and is able to get them casted. We also have a new surgeon starting in 2026 who happens to be here. Or was he? Where's Richard? So Richard's currently chief. And he's going out to San Diego to do his fellowship, and then coming back here to start in 2026. We still have clinic downtown, the Battle Building. Every day, one of us is there. We've also expanded to this building. We have 3 full days a week. Everybody but me sees patients here. I actually go up to Culpeper 1 day a week, and so it just didn't quite fit my schedule. And then Dr. Bachman also goes down to Bristol still 4 times a year. And if he can, drags patients up from there for surgery. We still have the motion analysis and motor performance lab. Unfortunately, when Kluge closed, it moved off site. And that's what you're seeing on the bottom right. It's actually down the road behind the Northridge building. And it's right next door to the fire department. Unfortunately, with that, it made it difficult for us to do clinical studies with this. That combined with insurance issues, we're really limited on how much we use it clinically, but it's still used as a research function for a lot of the divisions, and it's run by Sean Russell. That's our vision. So again, here's the 4 of us. Let's see, like I said, Keith, primarily, he's our focus guy for spine and sports. Emily's mainly, like I said, club feet, but she sees pretty much everything. She's pretty much an independent practitioner, but we're always there with her. Dr. Lather also sees a wide variety of patients, but we really like her for our metabolic type stuff. And then my focus is still neuromuscular with cerebral palsy, as well as a lot of deformity, both upper and lower extremity type stuff, including feet. We also have in our clinic, the nurses. The picture on the left was at the retirement of Karen Johnson, who's in the middle with the bandana on, and then with on the ends of our 2 nurses for the clinic. And then on the right picture is Dr. Lather with her clinic partner. This is Benicia, who's a female lab, goes by the name of Benny. But the lab sees patients with Dr. Lather, so she'll jump up on the bed, and it's been really helpful. They've even started, well, actually, they have a couple papers looking at patient responses to this, and there's one, it's going through the review process right now, so we hope to see that. And that's our division. So next, I'll have Dr. Bachman talk about spine.
Not spine.
Will you switch?
Yeah, I'd like to apologize to the 2 people in the room who wanted to hear the spine talk. But once we fleshed out a little bit more of the agenda for the day, and Dr. Abel and Dr. Yang are going to debate each other about spine, and Dr. Milbrandt is going to give us a fantastic talk about spine. I took Dr. Gwathmey's advice and we went with something that maybe some more people take care of. So I'm going to talk about pediatric femur fractures. Feeling like Dr. Shen up here not being able to make this work. All right, so we're going to run a little bit through the gambit, but you'll figure out kind of what some of the focus of the talk is. So we've got a 3-year-old male jumping into a foam pit. These are all cases from the last couple of months. I just kind of cruised through the board real quick and figured out, hey, what did we take care of here? So show of hands in the room, who wants to put a nail in this? Dr. Abel, excellent, good. Nobody else, all right, bummer. 6 plus 10-year-old male, snowboarding accident, who wants to put a nail in this? Dr. Weiss, Dr. Yang, Dr. Johnston, I'm assuming flexible nail, or you want to put a rigid nail in? Flexible, all right. 8-year-old sledding accident, some combination, nail, rigid or flexible still?
You gotta lock it.
Gotta lock it, only at TSRH. How about plate? Spica cast, anybody? No? All right. 8-year-old females trip and fall on the playground. Nail? Flexi? Rigid? Plate? Any of the above. All right. 10-and-a-half-year-old hemiplegic CP, but this is the contralateral side. So this is his good side. Nail? Rigid nail? More hands going up. All right. I like it. I like it. Plate? You could do that. Flexi nails? Nah, too old. What if you lock them, Dr. Johnson?
I think there's plenty of nails, the small synthese.
Yeah.
Perfect.
11-year-old sledding collision. Rigid nail? Now we're talking. Okay. And how about a 12-year-old got tackled playing football? Rigid nail? Maybe. Plate? Yeah. What about that little lesion down there? You want to get a piece of that? All right. So what does our academy give us in terms of ideas for this? So these are the clinical practice guidelines. They were most recently updated for pediatric femur fractures in 2020. The strong evidence that we have is that really young kids with femur fractures should be evaluated for child abuse. So that has strong evidence. And in 2020, these were updated to say that there is strong evidence for use of elastic intramedullary nails in patients 5 to 11 years old with diaphyseal femur fractures. Everything else is limited or moderate evidence, meaning you can kind of pick and choose what you want to do. But to the point where it is then, you have to temper the recommendation for the flexible nails, and Dr. Johnston hit on this. If you have heavier patients, older patients, length unstable fracture patterns, proximal location, distal location, there's a lot of factors that go into choosing when you're taking care of pediatric trauma patients, especially femur patients. There's a lot of options out there, but there are some that are going to be better and for certain fracture types, but it's not as simple as just, well, they're this age, we're going to use this device, to the point where some folks in the Yellow Journal in 2024 specifically focused review 5 to 11, and they came up with this really easy algorithm that you can follow. And we'll finish that real quick, and then we'll be able to just move on to the next talk. So this is it. That's it. That's all you have to do. Okay, so that's the algorithm. It's easy. 5 to 11, you just figure out what's on there. Okay, it's a little bit complicated from that standpoint. So what are the things that we do know? And the focus of this talk is mainly talking about using a rigid intramedullary nail for fixation of femur fractures in kids. And so when you look, the important thing is understanding, and hopefully everybody in the room knows, that we don't want to do a piriformis start nail in a kid because of the vascularity that's heading up to the femoral head. You have likelihood of potentially causing AVN from that standpoint. So you want to avoid the piriformis fossa just because of vascularity. And this was some of the early work, 2011, looking at that. Dr. Beatty, as well as some others, presented on their cases that they had with AVN with piriformis start nails. There was even some AVN risk when you look at troch start nails, so like we would use for intertrachs and various other things in adults. But the idea of lateral entry nailing, and at least in this 2011 talk, no evidence of causing AVN with a lateral entry nail in a kid. And so we then had some folks at Vanderbilt. This was 2014, publishing their 20-year experience of doing lateral entry nailing when we look at children's femur fractures. And over those 20 years, they had no cases of osteonecrosis. Now that lateral entry is going through the troch apophysis. And so there is risk when you look at that, especially in younger patients, when you can have some growth differential that occurs as a result of that. In their experience and in this paper, they did have an increase in that articular trochanteric distance, but they felt that it was only clinically significant in 2 of the patients that they found some asymptomatic coxavalga. They did not have any osteonecrosis. They noted 2 case reports of osteonecrosis with lateral entry nail. And when they reviewed those 2 cases, these are from other articles that were published by this time, because there were none in that 2011 review. They noted that there was a very medial start point. It was noted as a lateral entry nail, but a very medial start point with a large nail diameter, potentially tickling into that piriformis fossa. And then they had one case that said that the AVN was found at 20-year follow-up. So there was difficulty sort of correlating that to the nail, but certainly is possible. When they look at that articular trochanteric distance, Gage and Carey back in the 1980s noted that they were performing a apophysiodesis, really, of the greater trochanteric apophysis. And they noted that after age 8, so this is for patients with Perthes, and they noted that they didn't see significant change in the articular trochanteric distance if you perform that after age 8. And so when we start to look at rigid nailing as an option for pediatric femur fractures, if we potentially lead to an apophysiodesis at that point, if you start to get into the older population, we likely have safety from growth disturbance means. And so looking, this is that lateral entry. And so multiple different options on the market at this point. So looking, it's really, I describe it to the residents, put the nail where you think you should have started it when you were a PGY2 if you were doing a cephalomedullary nail. So you just kind of slide down the troch a little bit. And so if you think you're putting in a TFN as a PGY2, that's where we actually want to put ours. So not when big bad scary Dr. Yarborough is telling you, hey, you need to get medial with that thing, putting in the TFN. And so coming down to that lateral aspect. And just to prove it's not the PEDS folks, I put in a little OTA paper here. So although I think all of the authors are actually pediatric surgeons, but they published it in OTA, so the trauma folks can feel good about this. Okay, Dr. Weiss, this is not just our thing. So what's that? Yeah, open access. And so we can see this sort of preponderance or there's more papers populating the literature. And really, when you look, a rigid left rigid intramedullary nail, if anybody else in the room today had a femur fracture, we all are going to want our femur fractures treated with a rigid nail just because of the benefits of that. And so it is possible to provide that treatment for kids as well, and the benefits that we get in adults in terms of early ambulation and really being able to help get patients moving. So this was the Campbell Clinic group. And they were looking, so this was even, younger kids looking at that. And this is when they pivoted from piriformis start nail to lateral entry nail, talking about their early experience. This was before that Vanderbilt article. And again, noting no osteonecrosis, no malalignment. And so when that takes us, then you start to get people that want to push the limit a little bit. So we noted no age 8 articular trochanteric distance, that study from 1980. And so can we sneak down? These are some surgeons down in Orlando. And so they had 54 patients age 8 to 10, elastic nails versus rigid lateral entry nails. And they noted no osteonecrosis in either group and no clinically significant changes in anatomic parameters that they were measuring. So starting to look at potentially sneaking things a little bit younger, although I think that a lot of us doing this work would still think about plating in that 8 to 10 group if you need a more rigid fixation. So what do you do, or what are some things that we can do? So again, we've got this article with a nice picture from this standpoint, but we've also got the folks at CHOP who looked to kind of build a principle-based classification. So if you look at those clinical practice guidelines, they don't give you much to work with in terms of when you're looking at a case, what are your good options for these patients? And so they got together a working group looking at really kind of seasoned folks in the field of pediatric orthopedics to give people an idea of, okay, what are the things that we need to do? So if you look at class 1 in this, it's protect until healed. So these are incomplete fractures in younger patients, really young patients, and you're just protecting, you're giving some relief, but we generally think that that fracture is going to stay where you want it. And so you can really get these patients going with a walking spica or something along those lines until you see that early bone formation. Active cast treatment is what they called class 2. And so these are still younger patients, 6 months to 4 years old. You're going to have more routine early follow-up in those patients. You're actually holding a reduction in these patients. And so getting them back into clinic in all pediatric fracture care, it's not just put a cast on and then let it run. It's going to be ensuring that you're maintaining that reduction that you're shooting for. As the soft tissue parameters change, swelling goes down, their position may change. So these patients are going to come back a little bit earlier, make sure that you're not losing anything, and be ready to wedge a cast or do something during follow-up to still make that work for the patient. And then we get into more surgical fixation. So class 3, flexible fixation. This is the elastic nailing. And even in older patients, as long as they have appropriate fracture patterns, so length stable patterns, 2-part fractures, low energy trauma, and lighter weight patients. And then if you get into more rigid fixation, this is where you start talking about plating. Everybody has to throw X-Fix in there, but start talking about plating, and you start talking about rigid nail, submuscular plate for the more length unstable fractures, longer patterns, higher energy trauma, heavier patients, the things that really fit those needs, as well as then the class 5. So these are your polytrauma, life limb preservation, following damage control orthopedic principles, and then you find yourself back into the class that you need. So putting all of that together to be able to just give yourself a framework to work through if you find yourself taking care of children with femur fractures. And so we'll go back through those cases. And so we've got a 3-year-old foam pit. This is going to be that class 2, so active cast treatment. And we're going to see them back. We're going to put them in a cast, a little bit of valgus, a little bit of extension to avoid the typical drift that they're going to want to go through, active follow-up, and they're going to heal nicely. You get a differently rotated view when they see you in clinic, but then they start to heal and the beauty of pediatric bone takes over. We get into the slightly older patients, so snowboarding accident, higher energy trauma, but have fracture pattern that's amenable to flexible nail treatment. So we're into class 3 now. So we're going to look at this, and you see the abundant bone formation. And then we keep moving down. So 8-year-old male, we can see a lot of comminution at the fracture site. Rigid nail, if you're in Orlando, I think that'd be an option. This was a very young 8-year-old. And so we opted to plate this patient, but still falling into that class 4 sort of rigid fixation. If you have access to or are familiar with locking elastic nails, I suppose that could be an option there. So plating this patient, get a nice reduction, and you can see from a, there we go, results, abundant bone formation. He's moving along nicely. 8-year-old female, doesn't give the full story for this one, I would say. This was a 8-year-old female, very autistic, trip and fall on the playground, poor bone density, which we didn't discover until later. So we opted for rigid fixation for this initially, got what I thought was a nice reduction. And then she walked on it immediately. Probably could have put in a beefier plate. That's a 3-5. Just in general, when I hold a 4-5 plate, even the narrow 4-5 plate up against pediatric bone, it just looks enormous. And so generally going for 3-5. So this 8-year-old got converted to a nail. And that way she can stomp around on it and is doing lovely in follow-up, but unfortunately needed a second surgery for that. So even following those principles, you have to still consider all of the other factors in terms of what's the patient going to do. But, the beauty of being able to allow somebody to stomp around, maybe they're going to break an interlock or something if they do that, but generally your fracture is going to stay reduced. That's why, hey, if we can get into the realm where we're doing rigid nailing for these patients. So then hemiplegic CP, rigid fixation, he got a nail over here, early follow-up there, sledding collision, rigid fixation, nail. So Pediatric femur fractures are not as scary as they seem to be. So if anybody's, taking care of kids, rigid fixation exists. Just make sure you stay lateral, and you can do, so what you would do for more adult patients. This patient, that lesion, it looks like an NOF, but if we wanted to go get a sample of it to ensure at the time, we're going to have an approach for that. And so we opted for rigid fixation with a plate, and just to prove to Dr. Weiss that I can do tibial plateau surgery, if I can get the button to work. Maybe. There we go. So that's a tibial plateau plate turned upside down so that we can stay away from the physis and stay as proximal to the physis as we can, so that we don't end up with overgrowth. The closer your fixation gets to the physis, the more likely you might create some deformity, and the path came back as NOF. So thanks so much for everybody coming back. We have a great turnout from a PED standpoint this year, Dr. Johnson, Dr. Milbrandt, Dr. Yang. And so we're really looking forward to this weekend. I saw a hand. Hit me.
That locked nail in an 8-year-old, do you take that out later?
So the thing that ends up coming out in kids is the distal interlock typically, because as the distal femoral physis grows away, that that bone becomes more diaphyseal, and then this interlock looks like you put in something where you went, did you just guess on that length? It was appropriate when you put it in, and as that distal femur grows away, and they can get symptomatic from those. But typically what I do is just take out the interlocks. I don't bother taking out the nail. You just leave the rest of the nail and then you're good, because that's keeping your entry point open. And this isn't CME, but so Synthes, if you need to, the lateral entry nail just becomes the new adult recon lateral entry. And so you've got a 7.3 and an 8 in the adolescent nail set. And then if you need to go bigger than that, you just convert to the lateral entry recon set. It's exactly the same system, instruments, everything. So if that patient came in later, they still have a nail in, you access that nail, you take it out, you upsize to a lateral entry recon nail from Synthes, and you're good to go. So just ensuring that we've got that left there. Dr. Weiss.
What's a walking spica? There's no foot involved.
Yeah, so walking spica means that you're not including the ankle and you're not going 90-90. So 90-90 for, hip reduction, those things. So this is that sort of human position. So 30-30 at the hip, and you're generally doing only one leg for those. So it's really more a long leg cast with a pelvic band, and you're leaving the foot out so that as soon as they feel comfortable, they can start marching around on that thing. And at this point, the old adage was that you add 1 week to, so if they're 3, they're in for 3 weeks, and then 4 weeks, and then 5 weeks, and you just kind of go based on age. There's been newer studies that suggest that most kids with a spica, 3 to 4 weeks, and you can just take it off. And so I tell them as soon as they feel comfortable, if they want to walk in that spica, they can walk in the spica, because generally that means they have that early bone formation and they're going to get going. And then I breeze through it a little bit, but on the clinical practice guidelines, there's now really nice waterproof options for spica casts. So we have those waterproof Delta Dry liners. You just put the Delta Dry liner on them and wrap fiberglass over top of it. It's super nice. They can bathe, they can shower, and it's taken away a lot of the problems in terms of symptoms from that standpoint.
We've converted mostly to that functional brace for most.
We're looking at it.
And it's amazing. It's decompressed our operating room.
Yeah.
Our residents can put it on in the
emergency
room
department, yeah.
with a little bit of nasal fentanyl, and our reductions are basically equivocal to what we had in spica cast. Now, clearly one that is really short, really comminuted, you're going to have to probably get a better cast than what we see. But that has changed out of Lindsay Honors' work in Los Angeles. So I would, if anyone really wants to not put on spica cast, and they're an adult doctor, get a hold of this brace, because it's really easy to put.
So Orthopediatrics has it. It comes in multiple different sizes. You pick the size that fits the kid, and then it has all these hinges that you can tweak to change and get your parameters the way that you want them to get reduction. And then they're out in the ER. So thanks, everybody.
All right, so I'm gonna do a little bit of review and a little bit of what's new. I'll go quicker through the review stuff. But as I said, one of my niches is deformity correction. Everybody knows about genu-valgum. We have gotten a little more aggressive with treating these, just based on the amount of angulation, the fact that we know this causes more long-term problems, and we also have a very effective way of treating these with medial growth tether. And so here's a patient. You can see the mechanical axis on the right image is outside the plateau. So this patient is destined for lateral compartment problems. And a lot of these kids already have issues with the knees bumping against each other and getting in the way of their running and stuff like that. So they come in complaining already. But you can see it can actually get really aggressive. Some of the more pathologic types on the bottom left, I believe that's more of a Ricketts type situation. On the right shows you again, we're looking at our mechanical axis is our key indicator for surgery. In terms of the workup, you need to look at the family. Is there some type of skeletal dysplasia in this family? It's important to look at rotational profile. Do they have excessive aneurysm? Do they have tibial torsion? All these things that don't show up on your standing x-rays and are best picked up on exam. Also, in terms of lab screening, this is sort of our lab screening panel for patients with skeletal, poor skeletal development, and this helps pick up most of your conditions. So here's like I said, the treatment is medial tether. Usually the distal femur. Almost always when you do your mechanical assessment of the femur and the tibia, the deformity comes from the femoral side. So by doing your medial tether at the distal medial femur with growth, that corrects. You can see the example of that on the right. People also talked about doing bilateral plates for length tethering, which is another option with these plates too. So unfortunately, some of these kids, if they're older, the face is damaged from like fracture that's causing it, they might need an osteotomy instead. Then you got to deal with the length deformity as well as a rotational deformity. Everybody remembers all bad. So that's my phrase. Anterior lateral means you're at risk for congenital pseudoarthrosis of the tibia. Also, a high percentage of these patients have neurofibromatosis. At a young age, the best way to look for that is axillary or a groin freckling. I picked up a few kids and diagnosed them at age 2 or so with that. So these do not really improve with growth, but there have been some studies show that if you do not have a fracture, you can treat it with a brace until maturity. Tend to be more IM fixation for the littler kids, but now there's a newer treatment called the X Union. It's been around for almost a decade now. And I have an example of that I'll show you. And then they used to talk about amputation for this, but as I say, never mention the A word to a family in your first visit, especially because if you say amputation, they're not going to hear anything else you say, but rarely an option. So this is the X Union protocol. So it's really extensive. You actually resect the area of the pseudoarthrosis. You resect the interosseous membrane between the tibia and the fibula. You have a nail of both the tibia and the fibula, which sometimes the fibula is so small, you can only get like a 1.1 or 1.4 pin up there. And then in addition to that MRI, you have a plate for the tibia. And then the real kicker on this is you go up into the ilium and even though it's like 2 and 3 year olds, you're resecting and you're taking all the cancellous bone out of the ilium. So you actually go all the way down to the supraacetabular area, you go all the way back to the SI joint. And it's amazing how much cancellous bone you can get from these little 2 or 3 year olds. And you combine that, and you also take some of the periosteum off the ilium while you're there, and you put it through the skin mesher, and you use that mesh along with your cancellous bone and BMP, bone morphogenic protein, which people used to be afraid of doing this in kids using BMP, but it's now standard treatment. And then, so you wrap that around the tibia, and you also put the BMP and the graft in between the tibia and the fibula. So you're trying to get a solid union between the two, which is what you see on the right here. You can see the amount of bone formation here. Paley, of course, says it's 100% union, but everything he does is 100% good outcome. But it is really revolutionized sort of how CMT is treated, or CPT. So, in terms of leg length, that's kind of the standard stuff. They used to talk about 2 to 5 millimeters. The option is to shorten the long leg. But there's a lot of problems with that. There's even talk now, especially since we have better ways of lengthening with less morbidity. Some of these 2 to 5 centimeter zones are actually getting lengthening of their short leg. But to keep it simple, I always like to keep things simple. When I'm talking to the parents, I say your options are either shorten the long leg or lengthen the short leg. And that depends on their age, where they are, what their stature is. And that all goes kind of into the calculations for that. In terms of growth arrest, it's still a great procedure. It's an outpatient procedure. Weight bearing is tolerated. They just have a neomobilizer. They get moving quickly. But again, it has its limitations. It requires remaining growth. And some people cannot accept the fact that it shortens your mature height. Again, basically, we're still doing drill bit, curettes. And we've looked at doing it with image guidance and things like that. It's just not time and effective or cost effective, really. And we get good results with this with, again, low morbidity. But that is your rest, the long one, and then the short one keeps growing and catches up with it. You can also do acute shortenings. These are not popular, mainly because of the risk of delayed or non-union that you get with these. Even in, especially in the tibia, but sometimes in the femur, you get some delayed unions or stuff. So I tend to do these more like subtroch, and I'll put a nail in and get them walking right as quick as possible. And that's what this one is. So with that, but you can even see there, the lateral aspect of the cortex is still slow to heal. In terms of lengthening, a nice thing about it, it's not dependent on growing bones. There's definitely more flexibility when you do your lengthening. Do you want to do it, during the summer? Do you want to do it, between middle school and high school? But as I tell them, it's a major commitment. It's a little more frequent visits, not so much as in the past with the rings. Physical therapy, healing process is long. Generally, we say high complication rate or high problem rate. And it's not a complication, it's just a problem that delays your outcome. That's another Paley thing. We still use ring fixators for some of the smaller kids. It's the advantage of this is you can correct both the deformity and length at the same time, which you can't do with the intramedullary rods. But really, intramedullary rods kind of really changed the way we treat pure leg length discrepancies. So if you have a kid with a major discrepancy, you're going to wait to maybe do this when they're a little bit older, rather than doing the ring fixers when they're younger. Especially in the femur, it's a great tool for lengthening. There's basically 2 types out. The one on the left is magnetically driven, and that's the device that you put outside the leg, and it distracts the bone, similar to the magic construct for the spine. And then on the left is this is a transducer, so it's transcutaneous. So this is underneath the skin, and here's you lay this on top of that from outside the skin, and that's what drives the motor of that nail. But like I said, it's definitely changed. It gives us more options. People are even doing some of these in little kids where they put them not intramedullary, but they put it right next to the cortex and they fix it to the cortex. So even on a kid with open growth plates, you can put the distraction device. It's kind of like an internal fixator. So you fix it to the bone and lengthen it with that. So again, people are pushing the options on this. Here's one, this is kind of a standard example of it. On the right, you see 10 weeks post-op, you get the mature bone coming in. Again, femurs heal great. Tibia's always a little bit slower, just like with fractures as well. This is one I did. There's a kid who had a residual proximal femoral deformity from infection. You can see his lateral especially is very dramatic. He was actually talk about impingement, huh? Yeah, there you go. You want to scope that one? So because of that, we actually had to do, he also had some bony deformity lower down in the femur, so I actually had to do 2 osteotomy sites to get this in. Cool thing was he kind of distracted at both sites, which gave us more motion, and we were able to speed this up a little bit. There he is there. Oops, wrong one. Just the same kid, yeah. So we obtained, it took us 2 months to get him out to length. We got 50 millimeters were obtained. We then used a bone stimulator, and we had removal of the nail at 13 months. Some of you might have seen this before. It's one of my favorites, especially if it's related to pediatric orthopedics. So if the parents feel that you're a good person, that you understand their situation, that you're an expert in your field, and that you have their child's best interest at heart, they will likely find your argument persuasive. And this comes from Aristotle. So a lot of famous quotes out there. This is not a quote. But listen to your kids. They'll tell you. Thank you.
Welcome, everyone. So my UVA journey started in '97 in med school when Dr. Milbrandt's journey ended in med school and started in residency. I also worked in the lab with Gary Balian, with Anakar Chhabra, who I had dinner with last week. He is the same. He's very similar to his brother. Overachiever and all the good stuff. So our division has grown a lot. When I started, Dr. Chhabra was by himself in 2007. And we expanded, thankfully, because life was crazy then. So you can imagine this group was a lot smaller. When I was a medical student, Dr. Greg Degnan was here. He then was followed by Dr. Panunzio and then Chhabra, and then they all left him. I should have known that was a thing, and I maybe. But now, 18 years later, here we are. So the division has grown, and it's wonderful. So obviously, Dr. Chhabra started in 2002, myself in 2007. Dr. Deal came and saved us from our the pain that we were in 2009. We convinced Dr. Freilich to come back as a resident, come back. They both came from Wake Forest. And then a few years ago, Dr. Casey Peak joined us from Colorado. Dr. Brent George was a plastic surgery resident here, who came back on faculty in 2017, and he and Ava Chappelle spent a lot of time in our hand center upstairs. We developed a hand center in 2010, kind of following on the shoulders of Dr. McHugh, who was kind of the first hand surgeon in the area, and it has kind of grown exponentially. Dr. Chhabra obviously has grown exponentially as well in his impact as the building represents. And so we hope to continue this legacy as we go forward. We have 2 physician assistants. We had 1 at the time we started, who's now working with spine. And Amy Radigan and Kelsey Parente have both been here for over 10 years. They see over 14 years apiece. And they see an infinite number of patients, initial visits, follow-ups, post-ops, you name it. Their RVU totals are out or through the roof. And then our talks for today. So Dr. Aaron Freilich is going to speak on mediofemoral condyle grafting for scaphoid non-unions. Dr. Deal will speak on amyloidosis and carpal tunnel syndrome. And Dr. Peak will speak on arthroscopic scapholinate repair. She will not talk about TFCC because she will run out of time. So we appreciate everyone being here.
Well, thank you all for being here. It's really exciting to see everybody over here, seeing everybody come back. So I was asked to speak a little bit about something that we do. It's not 90% of the practice, a little bit unusual, but it's fun. And for a variety of reasons, both with the fellows and the residents. But I'm going to talk about medial femoral condyle vascular grafting for scaphoid non-unions and a couple other fun non-unions too. So is the problem, and we see it in hand surgery. So what do you do with these scaphoid non-unions? How do you treat them? They show up in a variety of ways. Sometimes they're a couple months old, sometimes they're a couple years old. Start to get deformity of the rest of the wrist. And what do you do about it as they're missed? And then there's more of these. What do you do about these? So you have a proximal pole non-union. Starts to become harder and harder to fix it. What about when they show up and somebody's already tried to fix it and they still have a non-union or they just missed entirely? What do you do with these patients? And it becomes a more and more difficult problem, and you have fewer and fewer options in terms of treating it. So there are a lot of different potential options, and partially because of being a referral center, partially because we have a hand fellowship. It's necessary, of course, to provide all of these different options, both for the patient, but also for education. So one option is certainly cancellous grafting from the distal radius or anywhere else, iliac crest, wherever you want, the tibia, the olecranon, you can take it from wherever you want. It doesn't even have to be vascularized. And sometimes that's the best option. So, you know, you can take a non-union that's maybe been there for a little while. You can miss the growth plate. You can take some good bone graft from the wrist. You can just pack it in there and put a good screw or two and get good fixation, and you can get these to heal. And the evidence is that up to 70% of these will heal just fine. You don't have to do anything fancy. But of course, some of these, you just can't do that. You don't have that option. You don't want to have that option. They don't want to go through that, or it's already been done and it's still failed. Another option is going to be a local pedicled vascularized graft. So maybe the problem is that they don't have vascularity. You got to bring some vascularity to the system and still do good carpentry. And you can certainly use a local pedicled vascularized graft from the distal radius and still keep it in the area. So you know, there's a bunch that have been described. There's just a couple of them, of course, the 1-2 ICSRA. So take it from the distal radius. Not something I do that often anymore. The vessel's tiny. It's not very satisfying. I don't even know if it's vascularized when I'm done with those. But that's an option. More recently, there are sort of what I would consider the orthopedic vascularized pedicled graft, in that you don't have to find a vessel at all. You just take a big chunk of the capsule with some distal radius attached to it, and you move it to the scaphoid, and you sort of cross your fingers and hope that somewhere in that big capsule is a vessel, and it's therefore vascularized, as described by Saterianos. And that works reasonably well. There are volar vascularized grafts, which make it a little bit easier to correct the humpback deformity. But they still rely on relatively small vessels. You get a relatively small piece of bone. And sometimes you can't correct the humpback deformity that has resulted from the non-union. You can certainly ignore it. There's nothing wrong with that. And some of these patients, that's the best option for them. They don't hurt that much. They have good motion. And yeah, sure, they'll develop some snack wrist later. But, you know, maybe you just ignore it and you leave it alone. You can take it out, and that's maybe the final pathway for a lot of these, is just quit on the scaphoid and just take it out entirely. Do a PRC, get rid of it. You don't have to fuse anything then. You can do a 4-corner fusion, capital lunate fusion. You can certainly make that better, and then you don't have to worry about the scaphoid healing or grafting it or anything else. Also a good option for a lot of patients, and certainly if everything has failed. And then a final option that I wanted to talk about is you can do a pedicle graft from the medial femoral condyle or the medial femoral trochlear if you need cartilage. And this is what we've been doing a little bit more for all the reasons that I've mentioned. So a little bit about the anatomy of the graft. It's a fairly large incision on the knee, so you can see everything, but from the medial knee, and you get a graft with a fairly long pedicle on it to be able to transfer to the knee, or from the knee to the wrist, and to tie into the radial artery. You can see there's a pretty predictable vascular anatomy there, and you can see you can take the graft on there. And if you follow that branch up towards the medial trochlea, you can take a cartilage-bearing graft with a vessel attached to it through the periosteum as well if you need to replace cartilage. Here's that anatomy right there, and you can see you kind of get this oblique shaped graft from the medial corner, and when you turn it upside down, you can put it in and you can replace the proximal pole of the scaphoid if you make that sort of oblique cut and fix it. The recipient site, usually I do these through a volar approach, especially for the medial femoral condyle, where I'm just taking a chunk of bone and not replacing the cartilage. And you can see the defects sort of freshened up and measured. You get nice parallel cuts. You can take a big giant chunk, 8 millimeters to a centimeter, and cram it in there, and you get good solid bone, good fixation, and you don't have to worry about trying to fudge putting a little wedge graft in there. Usually when this is done as a medial femoral condyle graft, you end up with this pedicle that you can tie in either to the volar branch of the radial artery if it's big enough, or you can do end to side into the radial artery a little bit more proximal. Relatively easy vascular anatomy and relatively easy microvascular anastomosis. When you take the trochlear graft, it ends up being the opposite. You flip it around and you can come dorsally, easier to get fixation, and then you can tie it into the snuff box as well. And again, same type of microvascular reconstruction, relatively easy, not tiny vessels, a couple millimeters at least. So here's an example. This is a 26-year-old with over 1-year-old non-union in the stiffness. You can see the humpback deformity and a lot of cystic changes. And it's certainly reasonable to argue that you can do a number of the things that I mentioned. But after discussion with the patient, ultimately they ended up having a medial femoral condyle graft. You can see the chunk of bone you can get and the correction of the humpback deformity. And ultimately this went on to heal. And they ended up with full strength, range of motion, and return to activity. So a good result. This is how we end up doing it. So a 2-surgeon approach. I don't do this alone. I do this with my colleagues in plastic surgery. That does several things. One, it makes it more fun. It's more fun to do these cases with another surgeon. We've started publishing on this, just showing the efficiency. You take a case that could take 6 to 8 hours if you ended up doing it by yourself. And we can now do these in under 4 hours. So still a large chunk of time, maybe something that can only be done at an academic center where they don't care if you take 4 hours to fix a scaphoid, but much more efficient. And we've started using that room for other cases, unlike what we did at the very beginning. We work in parallel. So at the same time preparing the wrist, I prepare the wrist. My colleague will end up harvesting this graft from the knee. And that is what really saves us time. And then we come back to the wrist as well. Other benefits of this is that it's really excellent sort of daytime controlled microvascular practice for our fellows and residents. And you're not trying to sew on a finger or a hand in the middle of the night and trying to teach microsurgery at that same time. It's very controlled, it's very easy, and it's very low stakes as well. This is how we treat them post-operatively. We've still ended up admitting them overnight for observation just because of how long the case is, make sure they don't have a big hematoma or other issues, they don't fall down when they start walking. We put them in an immobilizer just because we have drains in just overnight, making sure they're awake and they're stable. And then we get rid of that and start ranging the knee immediately. Weight bearing is tolerated. Some of these patients have needed PT. The vast majority haven't needed anything and they get back to stuff. A drain at the donor site to prevent seromas for between 3 and 7 days. And that gets pulled in clinic or by the patient. And then we've been still putting them in a long arm splint just to really shut them down, and then ultimately end up in a short arm cast for somewhere between 2 and 3 months until they're healed by a CT. Shorter for the MFT as well. So typical risks and complications, which we've seen in these patients, but by and large, they've done pretty well and end up healing uneventfully. You can, of course, use it for other things. So captate resurfacing, Kienbock's disease has been described, navicular non-unions in the foot, clavicle non-unions. So it can be a workhorse instead of taking a fibula or other vascularized graft. Here's just an example of the captate AVN with delamination of the cartilage. And ultimately, we ended up replacing that with a medial femoral trochlear graft, and they healed well without any pain. That's all I have. Thank you.
We'll do questions after these 3 quick talks.
Okay. Great. Thanks, Jalen. Hey, everybody. Kind of hard to see me if I stand back here, so I'm going to kind of stand over this way. So this subject is near and dear to my heart. So what is, thank you, Bobby. What is amyloidosis in the first place, and why should we care as orthopedic surgeons? So Oops. Okay, so amyloidosis is a misfolding of proteins. And what happens is then these proteins aggregate and they deposit in organ systems. They're insoluble and they result in organ dysfunction and organ failure. Two types of amyloidosis. It can be genetic or acquired. Acquired typically occurs with aging. There are two main types that we're going to talk about that are relevant to our profession in orthopedics. So the first type is AL, amyloid light chain. That is an overexpression by plasma cells of light chain amyloid that gets misfolded and aggregates into amyloid fibrils. The second is ATTR amyloidosis that also aggregates into fibrils. They both have sort of similar end results in that they produce end organ failure. They are produced, AL is produced by plasma cells and it is an acquired disorder. ATTR is produced by the liver and is in a healthy state. Transthyretin is used to transport thyroxine and retinol in the body, but there is disordered manufacturing that occurs. So AL is the most overall common amyloidosis, not to us. The mean age of diagnosis is 63 years old. It accumulates, as I said, kidneys, peripheral nervous system, but we're going to talk mostly about the heart today. It's very important to note that 20% of these patients have concomitant multiple myeloma diagnosis. ATTR can be genetic or wild type. The genetic ATTR prevalence is really low, but it's a very morbid condition to have. The median age of diagnosis for genetic ATTR is 39 years old. If you have somebody with a family history of amyloidosis, be very vigilant for this. It can have a variable penetrance. They may have no family history of it, and all of a sudden they have amyloidosis. The prevalence of wild type amyloidosis is unknown, but it is lovingly referred to as age-related amyloidosis as the incidence increases with age. So in a cadaveric study, cardiac samples from patients over 80 years old showed amyloidosis in over 25% of those patients. So what is cardiac amyloidosis? It's caused by AL and ATTR. The AL form is more aggressive. 70% of patients with these diagnoses will have cardiac amyloidosis. It's very important, and one of the big take homes from this is that if you have AL amyloidosis and you are untreated, your survival is 6 months after diagnosis. Your survival rate with ATTR is 4 years after diagnosis. So we are uniquely poised to diagnose this, and I'm going to tell you why and how shortly. But what this does is it infiltrates the myocardium and causes diastolic heart failure by not allowing the heart to expand and making a very stiff heart. It also causes arrhythmias, conduction blocks, aortic stenosis, and coronary artery disease. It can also affect the kidneys, the liver, GI tract, and the pulmonary function. So in our world, ATTR is far more common than AL. It's also associated with spinal stenosis. Frank Shen alluded to one of his patients having amyloidosis earlier. So 40% of patients who have surgery for lumbar stenosis, if a biopsy is taken, will test positive for amyloidosis. Hip and knee arthritis, 26% of patients who undergo arthroplasty will test positive if a synovial biopsy is taken at that time. It can also be implicated in rotator cuff pathology. Specific to my division, hand surgery manifestations, we see most commonly carpal tunnel, trigger finger. We see distal biceps tendon ruptures, which are very low energy or spontaneous ruptures. And we also see peripheral neuropathy. So in trigger fingers, the amyloid is deposited in the flexor tenosynovium. The incidence is unknown. We haven't studied this as much as we have carpal tunnel, but risk factors are age, male, multiple trigger digits, and particularly concomitant carpal tunnel. There's a median of 4.7 years from a trigger finger to the diagnosis of cardiac amyloidosis or disease. So when you see a patient with multiple trigger fingers or concomitant trigger finger and carpal tunnel, red flag. Okay, so that median is 3.1 years from diagnosis of carpal tunnel and trigger finger concomitantly to when they are diagnosed with cardiac amyloidosis. Also presents as peripheral neuropathy because the amyloid accumulates in the endoneurium. And your nerve test will show you that they have peripheral neuropathy. Obviously, it cannot tell you why, but if they're non-diabetic and they have peripheral neuropathy, red flag, look for amyloidosis. Spontaneous distal biceps tendon rupture or low energy spontaneous distal biceps tendon rupture. And this is really interesting because it's a secondary to the amyloid deposition in the tendon, but it's very interesting because review of patients with ATTR heart failure, 33% of those patients had previously had a low energy or spontaneous distal biceps tendon rupture as compared to 2.5% of patients with other causes of heart failure. This rupture occurs 5 years before patients are diagnosed with their cardiac amyloidosis. So it's another opportunity to intervene. And of course, in my world, carpal tunnel syndrome, amyloid accumulates in the transverse carpal ligament or in the tenosynovium, and up to 15 to 30% of men over 50 and women over 60 have amyloid deposits when you do their carpal tunnel. The risk factors are age, older age, male AFib, spinal stenosis, and bilateral carpal tunnel, and the majority of these are ATTR. And again, the diagnosis of this carpal tunnel precedes diagnosis of cardiac amyloidosis by 5 years. So why should we care? Because we have a chance to intervene and save lives. This really actually does save lives. So carpal tunnel, as we said, presents 5 years before cardiac involvement is noted. And once the cardiac involvement starts, it is irreversible. All we can do is prevent further damage. If you see here, this just shows you, I don't know where the little button is. Anyway, oh, here it is. Here, so carpal tunnel is way back here, and the cardiac symptoms about 5 years later occur. So if we intervene here, we have a big opportunity there. CTS is, as I said, the most common non-cardiac manifestation and is very frequently the first presentation of amyloidosis in greater than 50% of patients with carpal tunnel of amyloidosis. 50% carpal tunnel is the presenting symptoms. And lots of times people have carpal tunnel surgery and then several years later they're diagnosed with cardiac amyloidosis. What a missed opportunity. So just in the essence of time, I'm going to speed up a little bit here, but the algorithm that we use is two of these two items from tier 1 or one item from tier 1 and one item from tier 2. So most commonly people over 50 years old, males over 50 years old who have bilateral carpal tunnel, females over 60 years old who have bilateral carpal tunnel, they all get biopsied and then plus or minus some of these other guys. This is just a picture showing me taking a biopsy here from the ulnar leaflet, just to be sure I stay away from the recurrent motor branch of the median nerve. So our experience here, single surgeon, 842 carpal tunnel releases over a 5-year period, 182 biopsies following this algorithm. We had a 25% ATTR positive amyloid rate. The patients were positive patients were typically male, older, and had hypertension. No difference in race or diabetes. Males are 2.7 times, and hypertensive patients 2.8 times more likely. All our patients get referred to cardiology, and only 74% of them actually went. 32 patients are still actively followed by cardiology. 7 patients had advanced amyloidosis at the time of diagnosis, and 66% of our patients actually got started on pharmacologic interventions. And this just is our algorithm that we came up with. So if you have a presenting complaint that's concerning, you assess their risk factors based on the chart I showed you previously. Consider an intraoperative biopsy. That goes in formalin for Congo red staining. If it's positive, it goes for subtyping. If it's negative, you don't have to do anything else. If when you get it back, the subtyping shows ATTR, send them to a cardiologist. If it shows AL, they go to an oncologist. And the treatments are different based on what they have. If they end up having multiple myeloma, obviously they need additional treatment. So in summary, just a high association of specific diagnoses with amyloidosis. Please be vigilant. It's easy to screen for and make appropriate referrals. And that's it. Thank you.
All right, so I'm gonna try to keep this snappy, but I just wanted to say that I did not train here. I don't think I got a residency interview here. But I've never seen an alumni group that loves their residency as much as this one. And I see that at Hand Society every year, and I'm really excited to be a part of this department now. So I'm going to just talk about arthroscopic treatment of scapholunate ligament injuries. And I came from the University of Washington, where I was taught if I can do it with an open incision, why would I put a scope in it? So when I moved here, I was told, you got to start scoping things. And the arthroscopic impetus for scapholunate ligament injuries happened really last year when we started taking our fellows on a 1-week observership to another country. And last year they went to Lyon, France. And the fellows came back and they were like, the next scapholunate ligament injury that comes in, we got to do it with a scope. And so who's the attending who has that first injury? Me. And so I said, fine, but show me the evidence. And so the existing dogma from when I trained, and I think from when most of us trained, is that scapholunate stability is from the interosseous ligament. And so to restore that stability, we need to do an open repair reconstruction. And that has been going on since the 70s and on up. And I think the big things that we saw were, let's drill a bunch of tunnels through these bones and reconstruct it with a tendon or an internal brace. And I think that dogma is really being challenged these days. And so in 2019, Perez and Wolf published their paper that showed the importance of the external ligamentous stabilizers in scapholunate stability. We're seeing that there's this dorsal capsuloscapholunate septum that's incredibly important to stability in addition to the interosseous ligament, and then all of the other extrinsic ligaments and active stabilizers. We're now also seeing that diagnosis is different. So we shouldn't just be looking at these as, oh, we have an interosseous ligament injury, but each of these structures can impart some dynamic instability, and that's the European Wrist Arthroscopy Society classification. And so now when we see this, a 30-year-old woman walks in and she has some dynamic instability with scapholunate interval widening. We see on her MRI that she has a partial tear, primarily involving the dorsal aspect of the complex. We plan for this. We plan to go in with a scope, and I tried to speed this up for you. This is a big part of the procedure, a lot of debridement. And then we go in and we start to evaluate, well, what structures do we need to address? And here you can see we can't quite drive through, but we can really open it up. Some of her volar structures are still intact. And so for this, we plan to do a suture repair of the dorsal structures. So we make an incision on the back of the wrist connecting our portal sites, move your tendons out of the way, and then load up a 21 gauge needle with a 2.0 fiber wire stitch, go through half of the ligament, and then put that into your mid-carpal joint. And sorry, these are some of our earlier videos, and so I admit I wasn't as adept at my video taking yet. And then using a PDS suture, we go into the other half of the ligament, and then we pull those out of the mid-carpal joint through the dorsal capsule, pass them around so that then we can kind of shuttle them through and use that fiber wire to repair that dorsal complex. And here you can see we're pulling them through. I thought I had made this a little faster than I had. And then you'll see our reduction here. So the lunate's up, and then we push it down, we reduce it, we check our tension, and you can see now we can't get that probe in there, and the two bones are now level. And then we'll take it through the back and tie those through. All right, and so this is a flexible solution for a dynamic problem. We have repair strategies now that can fit the injury. So the suture repair is really great for dorsal tears, but we're also seeing that we can use it for volar tears. The group out of Mayo published this volar repair strategy that, let's see if we can get it to work, that we see here, that we have a volar tear, and then we can actually put a suture just through the volar aspect to repair that volar ligamentous complex. And then our group developed a technique using suture anchors for larger disruptions or big avulsions, using knotless fiber tack sutures to kind of recreate that reduction with something a little stronger, and then repair the dorsal capsule to it. So we're really trying to repair all of those structures that impart stability. And then there are other applications. So again, I had a very excited fellow when this guy walked into my clinic. Our residents got him reduced, and we decided to do an arthroscopic assisted debridement and then repair of his structures. And so here you can see he kind of busted up everything. We performed a dorsal and volar repair. Dorsal, we did anchors, and this is him at 9 months maintaining his reduction and stability. But he's a perilunate, so he's still pretty stiff. Post-operatively though, for these dorsal avulsions, I typically will treat them for 6 weeks in a short arm spica cast, and then get them moving with a brace for 4 weeks, and then strengthening at 10 to 12 weeks. And this is a patient who I treated. I think he was actually my first one, and he was doing really well, decided to come back at 6 months and show me that he was doing well when I got back from parental leave. So what have we learned? Scapulonate injuries are dynamic problems with multiple sites of injury, and so we need to be prepared to repair those in the appropriate manner. And arthroscopy is going to be the future tool of choice. It causes less damage to the capsule, ligaments, and nerves. It reduces damage to our carpal bones, which already have a pretty tenuous blood supply. And it repairs the stabilizing structures that are actually injured. A few tips that I had and that you could see in my video: you need to debride, or you're not going to see what you're doing. And then you need to choose the right tool for the lesion. And then this was something that Dr. Chhabra told me when I started: you need to scope everything you can, and you'll be able to scope anything you want. That's it.
It's been a great session so far. We are on to the home stretch for today. As Winston mentioned, we're going to have a little session here with adult reconstruction. It's nice to see so many alums back. I know we have alums from multiple different decades. Some of you may have been here at the time that Dr. Wong founded our division in the 90s. He also started our fellowship as well. So certainly we owe a lot to Dr. Wong for his vision and kicking us off. Some of you may have been here when this is how the division looked. There were a couple of other people in there, but we don't really talk about that much. But many of you might have been here when this is how the division looked. Of course, you all know Trey. And you may recognize the tall guy beside him. Some of you may not, though. And so for Todd and others, perhaps, I wanted to make sure that I augmented the photo appropriately. That may be how you remember Tom Brown. Many of you will know, of course, that Tom is now retired. He finally found a way out of Shawshank State Penitentiary. He successfully escaped. And so Tom is now retired. And I had the pleasure of joining 15 years ago. So many of you were here when this is how our division looked. And it's hard to believe, but it's been 15 years since I started here. I had the pleasure of being junior partner for that time. And it was brought home just how long it's been since I've been here. That picture is actually the picture that's hanging up in JPJ, that picture of the three of us. And I was there last weekend, and this is a buddy of mine from college. And he said, dude, you are unrecognizable. That's what he said to me. Those were his words. He said, I don't know who that guy is, but that is not you. So I clearly have aged a lot in 15 years, put on some gray hair, but there are some benefits to that. There's certainly benefits to being an old guy. Probably the primary benefit is that I'm no longer the junior partner. So I now have two junior partners of my own. Our division now includes Trey and myself, of course, but we have two fantastic junior partners. Ian Dunsing trained at Texas A&M, did residency at Utah and fellowship at Duke, and Tracy Borsinger did med school at Georgetown, residency at Dartmouth, and fellowship at HSS. And so the four of us are very busy doing total joints. Tracy's out, just had her first son. And so she won't be with us, but you'll get a chance to meet Ian here. So the way this will work is all three of us will give a brief talk. Hopefully we'll have a few minutes at the end to do some questions, and we'll try to make it interactive. And so without further ado, I'll introduce my senior partner, Trey. Trey's going to give us a talk about osteonecrosis.
Thank you, JB. Good afternoon, everybody. What a pleasure to be here, meeting so many alumni here. And I'm so fortunate to, being here for this many years, working with so collegiate and supportive faculty and hardworking, smart, our residents here. So this is 2005, my class. If you look at this picture, you can see what's a big difference from today, talking about the residency program. And, I'm so grateful for as my career continue to, develop. I wanted to thank my two important mentors, Dr. David Hankford at Johns Hopkins. He offered me a fellowship, so brought me from China to United States. After that, in 1994, Dr. Wang offered me a job here at the UVA. So that's 1994. We had a meeting at Hilton Head where I presented, my research on osteonecrosis. Actually, if you see at that time, Dr. Wang and Mrs. Wang, they were young and working with ARCO group. Actually, between Dr. Wang and Mrs. Wang, that's Dr. Zhang worked with Dr. Bennett at Duke University. So that time they did a lot of very fabulous. So that's a great opportunity to open, my eyes to get involved with the ARCO, that's Association Research Circulation Osseous. Think about it, you read a lot of literature, publications, but when you meet this, Dr. Jack Arlay and Dr. John Paul Jones, so all those big names, when you read those articles, you finally meet with them and work with them. So those are four big figures, in my career play a significant roles. So since that time, I have been involved with ARCO and, contribute and, collaborate and, basically continue to, make a lot of updates on how we are dealing with osteonecrosis. So later on, many years, I had the opportunity to work with leaders around the world. I'm going to show you some studies and also some updates to you today. So as you all know, classification system has been a bigger problem because we don't understand the osteonecrosis well. So everybody familiar with the FICAD and our late classification. Later on, Dr. Stenberg at UPenn developed his own classification. And then followed by ARCO classification, Japanese, Chinese classification. But all those classifications are outdated and not reliable and not validated, for so many years. So until 2013 in Chicago, so ARCO group decided to set up a workforce to develop a classification system and staging system to make it reproducible, meaningful, and simple to use for regular orthopedic surgeons. So this is a picture in Chicago. You can see Dr. Stenberg and Dr. Cruz from Korea, Dr. Ma behind him, they stand in the front. So Dr. Stenberg is really insists, his classification is more accurate than any other classification system. So we have a lot of discussions. Every year we have a debate and a discussion, how to develop this system, but was not successful until 2019. So we finally developed this task force and started working on this. So this is at that time we decided to use newer system. So you look at ARCO staging system, basically from FICAD 5-stage change to 1, you see that on X-ray, not a thing on X-ray, but you see that on MRI. So eliminate 0 stage. So you don't need to do pathology, but MRI, because that time available, will show pathology. And then stage 2 is X-ray abnormal, MRI also abnormal, but no collapse until to stage 3. So this is pretty much most important, border with the early and later stage. So stage 3, you will see subchondral fracture. Either femur head collapsed or you see subchondral fracture. That's already stage 3. So the treatment is going to be totally different. So if the depression less than 2 millimeter, that's early. If that's more than 2 millimeter, that's late 3B. But if you see arthritis, that's stage 4. So this is basically, if you compare with the other staging system, and I'm going to show you more pictures, you will realize the ARCO stage in 2019 is much simpler. And also started showing the inter-observer, intra-observer variation is much less. It's more reliable because it's easy to use. I'm sure you can use this anytime at this point. And then we don't know. So this is classification, staging system eliminated all that volume, percentage, all that stuff. So we still need a staging system, how we're going to predict if this lesion to collapse or not. So, and then that will dictate how we're going to treat this. So again, a lot of discussion until 2020 on July the 4th, I was on call. So I have time to work with Dr. Q, and then we sign up, including Dr. Winnie Novikov here, so PhD. So we designed this study on that day to do a study. So pretty much, let me see, actually just 3 types. If you draw a line from center of the femoral head, go to the dome, and then type 1 is on the medial part. If you pass the middle line, you involve the lateral portion, that's type 2. If you pass the edge of the acetabulum, that's type 3. Very easy to use. And then we compare that to modified Kerbal method, and then Japanese classification, and Dr. Steinberg's classification. So 4 different systems. You see, this is a modified Kerbal classification, but you have to use perfect mid-coronal and mid-surgical images. You have to measure. No way we can measure that clinic for most of the patients. And if you look at Dr. Steinberg, the way how to measure the lesion is even more complex. So this is really designed for researchers, not for clinicians. And Japanese classification is better, but osteonecrosis is not really involved with acetabulum. Why we need acetabulum? To only make it complex. So that's why basically we designed this simpler ones. And then we designed this study with Dr. Winnie Novikov. So look at how, if the diagnosis is going to be reliable, validated, and as predictable for collapse. So if we first 40 patients, we use a CT scan because we needed to decide if there are 3A or 2, because 3A you can see subchondral fracture. So CT scan is more reliable. And then we demonstrate, the normal classification or July the 4th classification, much reliable. And then next study, we did 104 patients. So continue check their predictability. And again, we show up this novel, much better than the JIC, the Japanese classification system compared with the other one. So this is still the best. So basically, at this point, the ARCO group developed this classification and staging system that's reproducible and is meaningful. This is prognostic and get the treatment and also simple to use. So 2022, we had a celebration in Seoul, this group, and of course, a lot of alcohol was involved. Had a great time there. And then after this, now we need to talk about how we're going to treat osteonecrosis, right? So as I mentioned, stage 3, that's pretty much the borderline. We needed to decide if we needed to preserve the femoral head or not. If you see the subchondral fracture, you see flattening of the femoral head, or you see arthritis, it's pretty much total joint replacement. And then stage 1, stage 2, you can provide any way to try to preserve the femoral head. So this is pretty much, if you look at the pioneer study by Dr. Ganji, and that's 2011. So that's a 5 years follow-up. If you do cortical compression only, 8 after 11 progress. If you use the bone marrow stem cells, 3 after 13 progress. So that's provide that time probably the best treatment. And then Dr. Hernigo in France looked at his own patient, 125 patients. So he used the cortical compression on one hip, and then cortical compression plus stem cells for the other hip. So he looked at how many cells he put in. It's between 45,000 to 180,000 nuclear cells into this femoral head after cortical compression. And his follow-up again demonstrated that stem cell can provide, better long-term results. So this at this time, pretty much this cortical compression plus stem cell therapy getting very popular. People use different ways to do the core and then to deliver cells to the femoral head. So the setup is you aspirate bone marrow stem cells from iliac crest, and then centrifuge it, collect the stem cells, and then deliver that to the femoral head after cortical compression. So do we have any evidence for this? Is this another milestone in medicine, basically? We don't have an answer yet. If you look at several clinical trials, use stem cells, all those are small sample size, shorter follow-up. But they do show, majority of them do show stem cells provide more benefit than just the core decompression. This is another one from India. However, there's another clinical trial in Korea showing no difference between those two stages. So we have a challenge there. So basically, ARCO group decided that at this point, we needed to do a multi-center clinical trial, including a mechanistic study. And so this is a group will only teach at ORS and AOS meetings. We also started to collaborate with the basic science and develop this study so we can only do clinical trial, not only do a clinical trial, but also work with scientists to look at a mechanistic study. So this is a multi-center study. We just started to enroll patients now. And if you have an early stage patient and will refer here, we will help them out. So this is a great, and then talking about a later stage osteonecrosis, as I mentioned, is a total hip arthroplasty. If they failed now, what do management, pretty much stage 3 and 4, they are indicated for total hip replacement. The evidence, we don't have a solid level 1 evidence, but from a systemic review with a meta-analysis, from 14 studies with more than 2 million hips, if you look at pretty much total hip and compare OA and osteonecrosis results about similar, except ON patient, they have a osteonecrosis patient that have a higher revision rate, periprosthetic fracture, and a PGI. So just keep that in mind. Even they're young, they have other medical issues. So basically, for conclusion of my talk, treatment of osteonecrosis is controversial and challenging. For joint preservation is for stage 1 and 2, and a total hip for stage 3 and 4. And I just want to mention that we're working on a clinical practice guidelines. We have several leaders in ARCO group, lead different topic with 3 groups will address this question. This guideline probably will come out next year. If you need any more information about osteonecrosis, this group also just published this book, a second edition for osteonecrosis. All the information included in this book. So that's all my talk. More than willing to answer some questions after this. Thank you.
Thanks, Trey. Obviously, we're lucky to have your knowledge, expertise, and leadership on that topic. Trey's been recognized internationally for his work on osteonecrosis. Next speaker, Ian Dunsing. Ian's going to talk to us about some of the clinical trials work that's ongoing here at UVA in the area of infection. That's sort of one of our areas of interest from a research standpoint. Ian's going to talk about that.
So UVA has been lucky enough to be involved in several multi-center trials over the last couple of years, and I've been lucky enough to be the site PI for a couple of these. So I'd like to just sort of give an update. The last alumni meeting, I think we were just enrolling in some of these. So we'll focus on one specifically on this talk. I have no relevant disclosures. I do have to admit, though, several of these slides were borrowed from the osteo presentation of their data during this year's academy. So some of the data is cut and paste from that. So this is an overview of one specific trial. It's the phase 2 FDA clinical trial, specifically APEX 1 and APEX 2, which stands for abbreviated protocol for the 2-stage exchange. So sponsored by Osteotherapeutics. APEX 1 finished enrollment here at UVA in 2023, and APEX 2 completed in 2024. These were multi-center randomized controlled trials. This was the development of this drug device combination program that was coined at the time VTX7, now called NextChange Kit. But basically, it's this abbreviated two-stage exchange for the treatment of periprosthetic joint infection of the hip and the knee. So briefly, explant of the hip or knee implant, there's a 7-day interstage period with antibiotic treatment and then reimplantation on day 7 through 10. Rationale for this is we haven't moved the needle on infection in a long, long time. So still, if you look at the data, there's 35% spacer retention, 20 to 50% reinfection and failure rate, depending on the study you're looking at. Extremely high cost for patients. Estimated cost of care, total cost of care around $500,000 for hip and knee infection. And as we all know, high complication rates and a huge variability in spacer type and spacer quality. Not all spacers are created equal. So this is sort of a general layout of the study. There were two of them, two phase 2 prospective randomized studies, Apex 1, Apex 2, 152 patients in total, all with periprosthetic joint infection of the hip or knee with a planned 2-stage exchange. Each study enrolled 76 subjects. Primary endpoints were evaluated at 90 days and 180 days, and then secondary endpoints at 6 months and 1 year. The phase 2 FDA clinical trial. So the point was to evaluate the safety and determine the efficacy of this drug device combination. So safety was characterized by assessing the incidence of adverse events. Study efficacy was determined by evaluating overall success at 90 days, 180 days, and 365 days. This was implant of permanent prosthesis, no or low mortality, no post-stage 2 PJI per the international consensus meeting. That's defined as a presence of a sinus tract, 2 or more positive cultures, or an accumulation or reaccumulation of inflammatory biomarkers, no revision surgery, either septic or aseptic, and no continued use of antibiotics at certain time points. So this is what the device looks like, just briefly. Wanted to go over the results of the study, not the study itself. But just briefly, this NextChange Kit, this is modular 2 or 3 components. These were assembled in situ. There's a communicating conduit that attached to the implant through a small opening in the skin and then attached directly to antibiotics for direct installation of these antibiotics into the joint space. This way it works for the knee is you have these 2 fenestrated cannulas that go into the femur and the tibia, this connecting intercalary piece that joins those 2 pieces through those screws. Those are size dependent based on the individual patient anatomy. Those are placed inside the joint, inside the intermedullary canals and connected at the joint level with this intercalary piece. And so that's kind of what it looks like. UVA experience, we had 9 total patients enroll, which actually put us in the top, doesn't sound like a lot, but put us in the top quartile of enrolling sites. We had 5 experimental patients, 4 controls, and then just the way the patients came in, there were 8 knees and 1 hip. So this is the overall flow from pre-screening down to the year-long visit. You can see those 2 the branches in the middle, stage 1 surgery with the 7-day interstage, and then on the right-hand side, the variable interstage period with a minimum of 8 weeks, but it was actually turned out to be much longer than that. Overall, no significant differences in any of the subject baseline demographics, including age, sex, BMI, or race between the 2 study groups. It's a breakdown of periprosthetic joint infection characteristics by randomization arm. So if you look at the bottom of the x-axis there, you can see the breakdown of these infections, primary versus refractory, culture negative versus culture positive, poly versus monomicrobial infections, and then those are gram-positive versus those are gram-negative. After analysis, there were no significant differences in PGI characteristics here. So FDA study, we're worried about safety. So one of the concerns was direct installation of antibiotics into the joint space. People were concerned about the systemic toxicity of some of these antibiotics. What were the serum concentrations? So specifically, is vancomycin and tobramycin instilled in different aliquots throughout the interstage period. And so when we look at the vancomycin levels, 32% of the samples had undetectable levels of vancomycin, serum levels of vancomycin. And those roughly 70% of people who did have detectable samples, the mean vancomycin level was 6.2 mics per mil, which is below the clinically acceptable target for continuous infusion of vancomycin. 2 patients had single vancomycin levels above those reference ranges, which then returned to normal. But most importantly, this dosage was modifiable or adjustable. So if a patient did have elevated serum concentrations of vancomycin or tobramycin, those doses could be adjusted. Similarly, with tobramycin, this was seen less as an issue, but still 60% of peak tobramycin levels and 84% of trough tobramycin levels were undetectable during the interstage period. And again, those mean peak tobramycin serum levels during the interstage period were below clinically acceptable levels. So overall, in terms of the safety based on the direct installation of antibiotics, it was deemed not to be a safety concern. So looking at the 6-month and 1-year overall success. Now, these are tiered successes based on the MSIS outcome results. So looking specifically at MSIS tier 1, which is the goal. This is infection control without suppressive or sustained or prolonged antibiotic use. You can see the difference here. So the next change group had 71% tier 1 success, standard of care at 52%, and that was statistically significant. MSIS tier 2, this is infection control with suppressive antibiotics. There was no significant difference there. MSIS tier 3 is a big category. This is any revision, aseptic or septic, before or after 1 year from the surgery. 3E is amputation. The only one that was statistically significantly different was 3F, which is the presence of a retained spacer. So 100% of the next change group did receive their final implant. 13% of the standard of care group had a retained spacer, and that was significant. No difference in mortality at 1 year. This is more of a visual graphical representation of that same data. So the green is that MSIS tier 1 success, 117 more days as a success compared to the control arm. Really the differences in these two graphs is the large portion of the orange there, which is again that retained spacer group had spacer for longer and more patients at that year-long visit that did have the presence of a spacer. Secondary outcomes. Looking at total mean surgery time, this is stage 1 and stage 2. So cumulative surgical time in the experimental group was 293 minutes, control is 355. So saving cumulative OR time of just over an hour. Percent of subjects completing stage 2, I've already mentioned this, 100% of patients had the final stage of stage 2 complete. Median time to stage 2 surgery, this was as expected. The experimental group had that 7-day interstage period. The control had a roughly on average about a 3-month window between the explant and reimplantation. Looking at PJI burden, overall PJI burden. This is days without a permanent prosthesis plus days spent in the hospital for PJI and or septic reoperation. There's an 84% reduction in PJI burden, 43% PJI burden in the control group. Antibiotic burden, there were 37 fewer days on enteral or parenteral antibiotics in the experimental group compared to the control group. This is, again, graphically sort of similar information, so I'll kind of breeze through this. Average days as an MSIS tier 1 success, 195 days versus 77 days. 100% permanent prosthesis, mean time to reimplantation, 7 versus 98, and then total surgical time, as I mentioned, was about an hour shorter. Patient-reported outcomes, how did patients do? Overall, looking at the patient-reported outcome measures that they were able to capture, there were greater quality of life improvement in the experimental cohort, was statistically significant. And they also had improvement in all KOOS dimension scales at all follow-up time points. So far, everything seemed to be going pretty well. This seemed to be certainly not inferior to the standard of care, but there was a catch that sort of emerged through analysis of the data, and that was that 8 out of 76 patients, 10.5% of patients had these Candida positive cultures during the stage 2 surgery, which is obviously much higher than the 1 to 3% rate of postoperative symptomatic fungal PJI cases reported in the literature, and much higher than the 1.3% of patients who had Candida isolates in the control arm in stage 2. All patients with Candida isolates were treated with systemic antifungals and standard of care if necessary, including IND, removal of the components of systemic antifungals. One of those 8 patients did develop a symptomatic Candida infection beyond the 365-day follow-up visit. This was also the only patient who had moderate growth compared to minimal growth or mild growth, and subsequently developed a polymicrobial infection required explant in a formal 2-stage. None of the other 7 patients presented with clinical signs or symptoms of fungal infection. None of them were on prolonged antifungals at that year visit. So as a result of this, the FDA required an expert panel to assemble and discuss etiology, outcomes, mitigation strategies, and overall recommendations. The panel had a long discussion and ultimately concluded that the benefits of this next change kit versus the standard of care outweigh the comparative risks as long as the individual surgeon is aware of these risks and can make their own decisions about whether or not the patients are going to be treated with this implant, including the risk of Candida infection, specifically at best measured by the lack of these observed failures secondary to positive fungal culture. So this was just recently, a couple of weeks ago, submitted to the FDA for further review. So ultimate decision still out, but interesting data at least, and potentially moving in the right direction on infection.
Thank you, Winston. It's been absolutely fabulous to have everybody come back. We really appreciate you guys doing that. Just cherish these moments, and we're really proud of the sports division. I think it's come a long way. I was sharing memories with people. It's grown now. Do these buttons work?
Down button.
Not the keyboard. Not the keyboard. This clicker. Yep. So we now have 6 faculty, 3 fellows. We cover 2 D1 universities, which is an amazing experience for the trainees here. These are our 6. So Dr. Miller's emeritus, but from left to right, we have Matt Deasy, who joined us this year. He's the most junior, Winston Gwathmey, myself, Steve Brockmeyer, Brian Werner, and Chuck Sue. So we have 2 people doing hip surgery, which makes for a fabulous learning experience. I think our fellows are able to make that part of their practice leaving here, which is not common at all for fellowship training. We got 3 guys doing major open shoulder. DC is kind of taking over for Mark Miller for complex knee. We got guys doing lots of osteotomies. I have some patellofemoral interests. So it's a very well-rounded fellowship. And just in terms of some things that we're doing that may be kind of new here. So fair number of cartilage procedures, osteochondral allografts. There's some on the patella, which is a complex surface to get right. We do more MACI than maybe some of you guys remember who trained here earlier. We were a little bit late to the game with that, probably for conservative concerns with costs, but have embraced it more, especially in the patellofemoral compartment. Those of you in the sports breakout a little while ago saw a case with this. This is a medial implanted shock absorber, which is obviously something brand new that we were part of clinical trials all the way through FDA approval and doing that. And that's how that works, where it loads towards extension. This is like a tube on end. It gets loaded and offloaded in flexion. So nice bridge before somebody's ready for arthroplasty. In the shoulder world, that's an arthroscopic posterior osteochondral allograft, correct, for the glenoid? Correct, is Stephen here?
Yeah, it's anterior.
Anterior, okay, but there you do some posterior ones too, which is even more complicated. And this is not my world, but this is a custom. What is this base plate here in this? 3D printed. Some really amazing stuff with regards to open shoulder cases here. And then in the hip world, labral repairs, labral reconstructions. This is one of Winston's cases, absolutely gorgeous reconstructions. And we saw a complicated case Winston presented in the sports breakout with a cam deformity and a rotational osteotomy of the femur, some really high level stuff. So pretty cool. We're doing a lot more osteotomies here too. This is a BodyCAD system, which is a CT based 3D printed custom cutting guide and custom plates. Allows us to do very complex deformities. That you get a 3D printed guide. Opening or closing wedges can control or can correct in multiple planes, from rotation to coronal plane to slope, everything else. And it really allows us to tackle some very complicated things, fixed patella dislocations, rotational, two biplanar osteotomies, sometimes dual osteotomies, really complicated stuff we're doing now. So that's it in a nutshell where we are with the sports division. These are some pictures from some of the championships that we won with the different sports. So I think I'll go right into my talk. Is that good? It's changed a lot from the days when it was just one person here, that's for sure. So just going to present some stuff I've learned along the way with patellofemoral. I do a lot of that now. And these are some lessons I've learned. So the disclosures, none really apply to this. How about those tan lines? She like to brace. So patella instability can be life-changing. The very next dislocation can be life-changing for these people. What I learned probably very early on, the first 10 years of our practice, we were doing imbrications and primary repairs. We thought they worked, but the problem is science comes along and you see really good studies where randomized to repair or non-op, it's the same, or in a 46% redislocation after repair. So good science shows us that that's going to fail. So you really have to use a graft if you want to reconstruct the anatomy. That's going to be much better. And then the key is where you put it. And I still use fluoro for every single case, and then confirm it by watching the osteotomy, the range of motion and the tension of the graft. One of the studies we did here was to come up with this phrase high and tight, and that green line is if it's too proximal, and obviously too much tension on the graft. So the first thing I've started to really learn is it's all about the vectors acting on the patella. In every case, I try to understand what's at play, and I assess these anatomic risk factors and try to quantify them as I make a treatment plan. This paper, a systematic review, showed that the more anatomic risk factors you have, the greater your risk of recurrent instability. So you have 3 or more, there's a 75% chance of redislocation. Counseling that first-time dislocator, 75% chance of a life-altering cartilage lesion, I'm going to be aggressive with that first-time dislocator. And certainly the more anatomic risk factors, the more likely the need to change the anatomy. So here's a case that highlights some of the things I've learned. So this is a well-done MPFL on one side, but never felt right. Diffusing, crepitus, still apprehensive, bit of a J sign, and still has a moving apprehension test that's unstable up to 90 degrees. So with the quads relaxed, as you try to sublux the patella, when does it lock in and you can't move it anymore? What degree of flexion with the quads relaxed? This is a good way to assess your outcomes with your reconstructions, and also to know side to side, is this instability, is this pain related giving way? It's also been called the instability reduction angle, but this is a pretty useful exam maneuver. So it's clearly asymmetric. Now, understanding the vectors, the TTTG is one that I think everybody knows how to measure, looking at a lateralized tubercle, but that doesn't really tell the whole story. And increasingly, I've learned, this is lesson number 3, that the PTLTR is a much better assessment of a lateral vector. So that stands for patella tendon lateral trochlear ridge. It's how many millimeters of tendon measured in the plane of the tendon sits lateral to a line perpendicular to here. That's at the apex of the lateral trochlear ridge. And it just makes sense when you look at it. How much tendon is draped over that corner? If the tendon's over here, there's no way you fix that problem by pulling the patella medial with a graft. It's going to fail. So this is I increasingly use this as a very useful assessment. And yes, it will be positive when the TTTG is normal. Here's a great example. So this patient, TTTG is 17, not alarmingly high, but PTLTR is 16, which is very high. It's most of her tendon sitting lateral to that apex of the ridge. It's a terrible vector. When does that happen? Typically when there are other risk factors such as patella alta and a little bit of valgus. And so then that patella is sitting up on that smooth part of the femur. Here her CD ratio is 1.35, which is high, and she's got some valgus. I've learned I get a long leg standing film on every case. I used to think I could eyeball it. I cannot. You really have to get these x-rays, and many times I'm surprised. Has a little bit of dysplasia, but because the patella sits high, it's on that round part of the femur, and it's got to travel further to get engaged in the groove, so that the alta makes everything else worse. So here's another paper that showed that the more anatomic risk factors you have, the more likely you are to fail an isolated MPFL. This patient has 4. That's why she failed. So what are we going to do? We're going to algorithmically approach this, and we're going to correct the PTLTR less than 5, which is in normal range, and the CD ratio down to 1.1. When you do a 2-tailed MPFL, you get an additional 0.1. So you're basically correcting your CD ratio to normal, which is 1.0. And just do the math, and you know how far to move the tubercle over and down, and then get a new tunnel for your next MPFL. And this worked great. This patient did very well. So some more lessons. Another patient felt so great. This is at 7 weeks after a physiosparing MPFL and tubercle osteotomy, that they decided to play soccer at 7 weeks post-op, and they got this fracture. So they met my trauma partner, Dr. Weiss, who was kind enough to plate this. So lesson number 5, you can't trust teenagers. The other thing is this shingle, where it's tapered distally, can crack. It really does behave like wood in a wedge. And as you tighten that bottom screw down, sometimes that can split. it'll go up to that screw, and I've seen it continue to split proximally to the top screw, and then it's a race to heal. If you recognize it intra-op, you can put additional screws, but this has prompted me, here you can see on the lateral view, this is one I've moved distally. So over where it's overhanging, that's where you're going to potentially split it. But I now put a third screw off axis, and I've never seen the split zigzag. Oops, hitting the wrong button there. So that's a routine for me now to put a third screw off axis. You see that middle one is going from a slightly different angle. And really these people need a protective weight bearing for a full 6 weeks and a brace. And if they don't, and if they're foolish like that teenager, they can pull things off. This can happen. And then that's a bit more of a problem. This patient didn't come back for follow-up until 6 weeks out, and this is how they presented. So then you're putting things back together with screws and washers and pulling it down, and things don't quite fit the same after it's been like that for 6 weeks, but this did work for this guy. So a little bit about osteochondral defects, chondral defects. So osteochondral allograft plugs can be pretty useful in this area, but there's some lessons to be learned there. We're doing more MACI, I think, for patellofemoral lesions, which has been a good addition for larger lesions, and plugs for maybe smaller lesions. But understand that these plugs, when you get an osteochondral allograft, it comes from the femur, and you're putting it in the patella, and there's a mismatch for your cartilage thickness. The patella is the thickest cartilage in the body. The femur is much thinner. So if your surface is flush, there's something different going on underneath. So here's a patient that came to me after having surgery previously with 2 10-millimeter allograft plugs, and the x-rays don't look too concerning, but they were really struggling and having pain. Here's an MRI, and those surfaces look pretty flush, which would be what the surgeon would see intraoperatively. Okay, I did a good job. Those surfaces, that surface is flush. And intra-op, you say, well, it looks worn, but the surface looks pretty flush. Well, here's a CT scan. And this highlights the problem with the thin cartilage from the plug versus the thick cartilage recipient. So your plug is proud. So you guys all remember, pressure is force divided by area. Contact forces are huge, 5 times your body weight, the patellofemoral compartment. That's all concentrated on that surface. So that's why this patient was just miserable. And you get in there intra-op, there's the second plug, that was recessed, that one's stable. And this is the one below that was getting all that pressure. And you can see what's happening, it's pressure overload. So this required a revision, osteochondral allograft from a patella, whole fresh patella, and sunk deep to match the bone surface. So that's the point of this. If you're going to use plugs, you got to match the bony contour with the surrounding bone, or you're going to get pressure overload. So in terms of trochlear dysplasia, it's going to be a black box for a lot of people. Understand that dysplasia does not occur in isolation. So this happens developmentally as a kid grows, and there's abnormal vectors that are acting on that patella to contribute to it. So here's a patient. Almost always they start instability very young, age 8. That's a common story. Terrible vectors, jumping J sign as they extend, and they have this large prominence, which is the entire trochlear base. You can measure the crossing sign where the base of the trochlear groove meets the condyle. It extends anteriorly where those yellow dots are. That's the prominence there. And on the axial view, you can see the patella on those yellow dots is sitting lateral to this. So the real problem with trochlear dysplasia when you have to intervene is when you have a convex surface where the patella is going to rest. And that's a case like this. But you've got to also correct the vector. So here's another example. This patient CTTG is 21, high, but not crazy high, but the entire tendon is sitting outside the trochlear groove. So that's also called off track. So there's no way you can solve this problem without fixing the vector, and you got to correct the problem with that convexity. This really highlights how vector is effective. This is this patient under anesthesia. The foot's externally rotated. Look at how deep flexion before the patella pops back over, because you're accentuating their lateral vector. Internally rotate this. As you flex them up, you've corrected that jumping J sign. And this is what the quad's relaxed. So for this patient, it required a deepening trochleoplasty, get rid of that prominence and that convexity, and also correct the tibial tubercle, in this case, moving it distal and moving it over. So flatness is not the indication, it's a convex shape. Flat on flat can be balanced. It's that convex surface, if that's where it's left, that's a problem, because that's like an egg on a table. Here's another case that highlights this. This is a patient had a well-done TTO, MPFL, corrected all their numbers. Their TTGG now is great. Their height is great. A little bit of valgus, but they still have a jumping J sign. Why? Because they still have this convex surface where the patella is left to rest. So if you make the other corrections and you try to distalize and medialize, it's going to fail if it's left sitting on a convex surface. But a trochleoplasty can't really fix everything. It's not going to create a contained surface for the patella. It's not going to hold the patella in place. It's just going to help improve congruity. So here's a patient that highlighted this to me. I did what I thought was a beautiful set of trochleoplasties on both sides, staged. I thought they looked gorgeous. But 3 years out from surgery, they came back and the J sign is returned. She's not dislocating, but she's doing this again, clearly not happy. What I hadn't done was correct her vector. She had 7 degrees of valgus, and she had still a patella tendon sitting draped over the edge. You see that post-stroke MRI axial cut there, which highlights this problem. So I went back, did the DFO, moved the tubercle over. So the next thing I think really highlights all of these, and that is patella alta makes all of the anatomic risk factors worse. Your patella starts higher. Any other vectors that are in play has more impact on that patella until it's going to find the trochlean and deep flexion. Here's a case that highlights this very well. 13 years of age, had a failed MPFL done outside hospital, had a J sign, recurrent instability, and came in and they have a lot of valgus. So I said, okay, I'm going to correct the valgus here and do a new MPFL. But if you watch from distal to proximal, here's the tendon sitting over the edge on your axial cut there on the right. Most of the tendons over the edge, high PTTR. Here's the mid part of the patella. It's on a convex surface. So I didn't recognize the need to change this, but I'm focusing on the vector by changing the valgus. And I did a great osteotomy. Now her plumb line looks terrific. You can see where she had some cartilage damage from this instability. I was concerned about doing a trochleoplasty at the same time as a DFO. Here's an interesting set of x-rays, just a little bit more flexion on the right. And you can see how she engages the groove. And the problem is when she's more at extension, she's still on that convex surface. Took out our hardware, still having trouble. Apprehension, still has an unstable patella up to about 60 degrees. So not completely dislocating, but subluxing and not great. And here's the problem, is she's still resting on a convex surface. So from proximal to distal, you see that mid part of the patella and the cartilage is on a convex surface. So the patella is going to sit tilted. It has to. It's going to make contact there, and it's going to be like that egg on a table. And you still have, even now, we've corrected the TTTG to 11. That should be great. But the PTLTR is still high because it's sitting on that convex surface and it's going to sit tilted, and the tendon's over the side and it's pulling it to the side. So this is when we had to go back in. Now we got to do a TTO and medialize that and distalize that tubercle, and we're going to do a deepening trochleoplasty and get it off that convex surface. So that solves the problem. So some take-home messages: patella alta and dysplasia is a very bad combination. You got to always do something more than an MPFL. Same with the jumping J sign, and really understand these vectors and what's at play. Flat's fine, but a convex surface is the problem. And a trochleoplasty doesn't fix it all. You still got to correct the vector. So those are some lessons I've learned. Thank you. Now, Matt DC's going to talk to us about some complex osteotomy stuff.
Well, as always, a very tough act to follow, but I'll try to make it brief. We'll stay on topic. It's wonderful to see everybody this morning. We'll talk a little bit about osteotomies, about the knee. So I've learned the fundamentals of knee surgery here, not only from our sports division, but from our arthroplasty surgeons. So it's not simply about varus and valgus, the meniscus, cruciates, keeping the saws from binding up in Dr. Brown's OR. It's about the patient. So you got to learn how to take care of the patient and what they bring. I was very lucky to go to fellowship at Stedman with people like Dr. Gill, a distinguished UVA alum. Learned a lot through high volume and complex knee cases, learned about whole limb alignment, something that Dr. Dudek brought up in his talk here today, and learned how to do the timeout alone during fellowship. I went for 1 year to the Rothman Institute, learned that surgery is very hard. Luckily, there were not residents and fellows there to learn how surgery was hard for me. And I learned that decision-making beforehand is even more important than slick hands in the OR. And from Dr. Chabra, I learned most of all that humility it comes at the forefront of all this. You got to be a servant and a leader at the same time in the OR. Speaking of humility, Aaron Casp and Michelle Q are two of the people who inspired me to go into sports. They were awesome residents, really smart people. And I know that there's no way that I would have been successful as a resident, a fellow, or in my position now without Michelle and Aaron, among others in the audience, but I can't not acknowledge them. So thank you guys very much. Real quickly, we'll go through preservation principles. I think this Venn diagram is very helpful when considering how to save somebody's knee, how to keep them out of Dr. Quay's OR for as long as possible. Not because they won't get a total knee, but because it's fun to try to save it. So we got to consider the alignment, the meniscal status, the ligamentous stability, and that's how we save the cartilage for as long as possible. We want to make sure we don't miss the forest for the trees. This is often what gets referred in the sports clinic. You got an MRI, you got arrows, you got to go fix that problem, right? They got a meniscus tear. But it's more than just the MRI. And it's more than just an x-ray view. Dr. Yarbrough taught me early on, one view is no views, so you got to get the full workup. Most important to me is to think about the lateral compartment on a standing flexion view, because the lateral compartment disease often hides on that standing AP. So we want to get our standard imaging. I like to think that long-standing problems should get long-standing film. So for all our patellofemoral folks or anybody who's had a knee problem that's more than just a couple of weeks old, you might as well get a long-standing film. The most sensible way for me to measure this, and the easiest way I found to explain to patients, is to go on that far left side of the image, which is the mechanical axis. It's very easy to show people asymmetry between the mechanical axis on their affected side and the other side. So I like to think of progression across from medial to lateral, from 0% at the medial edge of the tibial plateau to 100% on the lateral. And that's how I sort of make decisions and have conversations. We can skip the basic knowledge here because we got about 3 minutes to get 15 in. But it's important to note where the deformity is, right? Do people have varus from the tibia? Oftentimes, yes. That's the most often source of our varus deformity is the proximal tibia. Do they have femoral deformity from the distal femur? Most often, that's where it's going to be, but you want to consider these angles that we all learned for the OITE. Scott Yang apparently learned best of all, because Dr. Warner still tells us about his perfect score. So we'll move through here. This is a very advanced diagram. I hope everyone can follow here. It's solid Microsoft Paint. But important to consider that the lateral side of the knee is much less tolerant of meniscal injury and cartilage injury and can progress to really bad problems pretty quickly. So the lateral side is like the pancreas of the knee. Armando Vidal told me that, and he used some crude language to describe it, but you don't mess with it, is essentially the story. All right, so you got to take care on the lateral side. Pressure equals force over area. Again, that's Dr. Vidal and Dr. Didak are the two people that reminded me that that's really how we should think about this thing. Think about the hostility in either compartment. A total lateral meniscectomy will, double, triple, quadruple the contact pressures, whereas the medial side is much more congruent. It's much more of a concave and convex setup as opposed to convex on the lateral side. The knee is an organ. This is something we talked a ton about with Armando. And there's recent literature showing that a knee osteotomy, whether a distal femoral osteotomy or a high tibial osteotomy, can decrease the inflammatory process in a knee, and I think can prevent osteoarthritis, or at least delay its progression. So this is real science, not just our hopes and dreams. When we talk about ligamentous stability, obviously someone without an ACL, without an LCL, without an MCL that's functioning is not going to have a knee that's preservable if you don't provide ligamentous stability. Dr. Critch and the folks at Mayo taught us a lot about why our cartilage procedures fail, right? We have osteochondral allograft, osteochondral autograft, MACI, all kinds of fancy, very expensive procedures. And patients with untreated malalignment did worse than those patients who had appropriate alignment with these procedures. So we got to think about the biomechanical environment into which we're placing these fancy cartilage grafts. And they've done both biomechanical studies and patient outcome studies saying that if we were to do a cartilage procedure in a hostile biomechanical environment, it's not going to do as well. So we're just keeping it basic. So the osteotomies that we have on our menu are the tibial tubercle osteotomy that Dr. Diak just spent some time teaching us about and knows more about than maybe anybody in the world. So important to listen to him. That's great for correcting maltracking and can also offload or unload cartilage procedures on the tibia or on the patella, pardon me. DFO can address patellofemoral tracking, right? That valgus will pull the vector of the patella so that it won't dislocate laterally. So it can address patellofemoral issues, but can also address knee malalignment. An opening wedge lateral distal femoral osteotomy is less demanding. It's more comfortable from an approach perspective, but it's less stable at time 0. Whereas a closing wedge medial osteotomy, you're closing down that space. So you're compressing at the fracture site you create. So it's a little bit more diligence, but the reward is weight bearing early on. And then a high tibial osteotomy is the workhorse for treating varus deformity. And it also addresses flexion and extension issues. Whereas when you correct the distal femur, you're correcting the extension. You're not correcting flexion problems. So who gets an osteotomy at the University of Virginia? So this is a 14-year-old female who came to see me about 2 weeks into practice. I was like, perfect, very simple problem. I'm happy to get started. So she had progressive lateral sided left knee pain. She'd had a subchondral bone grafting done well by another surgeon in 2023, but things progressed. She had collapsed, and her goal was to be able to walk around school. She's not trying to get back and play college sports, professional sports. She wants to be able to walk at school without pain. So we did the appropriate workup for her. Her bone age, unfortunately, was about 17 years, so she had really no growth remaining. So our guided growth was not going to be an option for her. So we had a discussion with the family and made a plan to do a distal femoral osteotomy to correct her valgus alignment and unload her cartilage. So Dr. Hoggard came in and hung out on this one. He was finished in the OR, so it's great to have his expert hands. And I think we had a wonderful outcome for her. And she's walking around school feeling like a normal 14-year-old again. So I think we matched our plan pretty well. We used the BodyCAD system. And for those who are unfamiliar, I think it's a really nice way to make a plan. We sort of measure by the micrometer. We put a chalk mark on it and we hit it with the buzzsaw, was Tom Brown's old saying. I think this keeps it closer to the micrometer than hitting it with the saw. So she had, I think, great success there. So who else gets an osteotomy? This is a 40-year-old gentleman who had right-sided knee pain. I don't know, gentleman might be an exaggeration. He's a 40-year-old man who had right-sided knee pain for years. And he was supposed to have an osteochondral allograft with Dr. Miller. He missed 3 scheduled OCA procedures due to incarceration and just kind of not being around. But you know what? I thought we'd give him a shot to try to save his knee. We'll see. Dr. Brockmeyer likes to say that complicated or simple patients should get simple surgeries. But, I think he can get a nice complex one. His goal was to work and have fewer deep painful effusions. So he's got this pre-osteochondral fragment and progressive varus deformity that's asymmetric from the other side. So I think he's a good candidate. So we made a nice plan for him. I think we matched our plan pretty well. Dr. Miller got to experience the multi-step, very safe osteotomy procedure with BodyCAD. And his one comment was, I think we would have been done 40 minutes ago if we just used the saw. But I think he got a nice osteochondral graft. So you can see it, the cartilage, it was just missing. That was about a 3-second loose body removal. It just popped out of the knee. It was about the size of a quarter. And he got a large osteochondral allograft that we recessed. We made sure because of the lessons learned from sort of proud bone grafts. You can see on his post-op x-rays. Oh, we skipped it. Well, I think they're probably in there, the post-op x-rays, but he's doing well. So we have a 17-year-old female who had patellar instability, right? She had recurrent patellar instability and she had progressive lateral sided pain. So she got a valgus deformity, patellar instability, lateral sided early chondral wear. And her goal was to walk at school without fear of pain and patellofemoral instability. So we discussed with her a combined osteotomy or a staged approach. Our hope was that we could correct her PT-LTR enough with the first surgery that she wouldn't need anything else. So you can see the bottom image on the right there. That's her post-op PT-LTR compared to her pre-op, which I think I covered up in both cases, unfortunately. But she was sitting, her PT-LTR first go around was about 50%, it was 12 after prior to surgery. We corrected that. She still had some patellar instability. So we talked with her about the second surgery. She actually had a plate removal and a tibial tubercle osteotomy, and she's doing fantastic. So she's loving it after the removal of the plate and the TTO. So our osteotomies can help these folks to get back to living life. So who else gets an osteotomy? So this is a 49-year-old guy. So he's a 49-year-old guy, works in finance. He definitely pronounces it that way. He had insidious onset of medial-sided right knee pain. He's got progressive varus deformity. He'd had a partial meniscectomy in the city, as some would call it. New York is the city he was referring to, but he was a finance guy from the city. So he had a partial medial meniscectomy. His goal was to play tennis, play golf, play with the kids. He's got lots of leisure time because he didn't spend his 20s and 30s accruing debt. So he'd be a perfect candidate. But so you can see in the back, we got Dr. Brockmeyer, Dr. Brown back there. He talked to both of them. Dr. Brockmeyer said, this is the guy. You got to go see him for an osteotomy. And Dr. Brown said, you're going to get a total knee someday, man. You probably don't want an osteotomy. And you know what? He got a partial medial meniscectomy. He's got some cartilage wear there. I think he would have been a great osteotomy candidate on paper, but he didn't want one. So he did great with the medial meniscectomy. And I think that's where it's important that we don't let technology triumph over reason. We don't let a cool surgery, bias us to give people something they don't need. He did great with the partial medial mastectomy. He's really happy he was able to enjoy his fall and his spring so far. And he'll come back and get an osteotomy, I don't know, July 1st. And I think he'll do really well. But I think there are a couple things because time is short. And we don't need to lean on too many lampposts of research that are coming up in the next slide. I think osteotomy is a very powerful tool, and we have the ability to plan it more thoughtfully and have parameters to check our plan in the operating room. So it's not just a Bovie cord and rotate the leg till it's in the, you know, the place where we want it to be. I've been very fortunate to have incredible mentors here, not only in the sports division, but the trauma division, the spine, foot and ankle. I think it's the best place in the world to do orthopedics. That's why I moved my family 2 times within the span of like 6 months to be here again. I'm grateful to see all the faces from out of town, and even more grateful to my partners. I think it's the best place in the world to practice orthopedics. So thank you all for listening.
I'm gonna just give a brief overview of our division. Dr. Park's our division head. He just finished up in the OR. So when I was I did not do my residency here, but I was in medical school here from 1999 to 2003. And I was lucky enough to spend some time with Dr. Hurwitz back then. I'm not sure how much he remembers me on his service. Probably not that much. I don't know. I didn't do anything bad, so I think that's good. But I do see a lot of familiar faces here this weekend from people that were residents when I was a medical student, and you know, I think it brings back that memory of how much impact people may have on you that are above you, and as you go through, and you learn a lot as you go. And so, really happy to see everybody. Our division has changed and grown a lot over the years. We're still lucky enough that Dr. Hurwitz spends time with us and is always there to listen or give advice. Dr. Park is the first one of us to be here. He's been here since 2010. And then Dr. Paramal was his fellow. And then I joined in 2014 after a few years in private practice. And then Dr. Tippett joined us 3 years ago, is really spearheading our limb preservation program, which he's going to talk about. We also have 3 great PAs, but we're continually growing. We're very busy. This is just basically what I've just shared with you. We take care of UVA and JMU teams. It's been really fun. Dr. Paramal is going to talk to you a little bit about some MIS surgery, and he's been sort of promoting that and leading our charge. You know, that's been a big topic in foot and ankle. Again, I mentioned Dr. Tippett, and then Dr. Park is our division head and kind of been leading all this. And we're lucky enough, like I said, still have our sort of mentor, Dr. Hurwitz here. I'm going to, in the interest of time, I'm going to kind of go through my slides really quickly. I was going to talk about, yes, Jesse Seaman just beat me in a debate. So I'm just going to briefly tell you why I do still open management of insertional Achilles tendinopathy, and just kind of set up my partner, Dr. Paramal, to talk about his MIS ventures with this. But basically, I don't have any disclosures related to this. Insertional Achilles tendinopathy is really a syndrome more than a specific entity. You know, you get degeneration of the Achilles tendon, enthesiopathy of the bone formation of the tendon, a Haglund's deformity perhaps present, and then retrocalcaneal bursitis. And so it's really this combination of things that leads to pain at the back of the heel. And again, this is what an MRI may look like of that. That's the tendinopathy. There's some neovascularization. Enthesiopathy is that bone formation, which is really strange because there's a lot of people that you get an x-ray for other reasons. They have a huge bony prominence back there and absolutely zero pain. Haglund's deformity, you know, there's some controversy as to how much this really plays a role into this. One of our former fellows did a study recently and showed there wasn't really any difference between controls and people who had Achilles tendon pain and the size of this prominence, but that's what the Haglund's deformity actually is. Retrocalcaneal bursitis is something, you know, it doesn't usually occur in isolation, except maybe occasionally in a young athlete. Most of these patients that we're talking about are older, more sedentary individuals, actually. The epidemiology, like I said, mostly older, sedentary people. Non-operative treatment for insertional stuff is much less successful than the mid-substance Achilles tendinopathy, especially once they get to a point where they can't wear shoes and they're cutting out the back of their shoe like that. Surgical treatment, again, I'm going to be brief here. There's a lot of interest in minimally invasive surgery throughout orthopedics. And sometimes I feel like we're doing things because we can. I still favor an open approach for this. It's had great results. The downsides are very low. The infection rate's low. Complication rate's low. I can do it through about a 4-centimeter incision. Take the peritoneum, save that for later closure. I think that really decreases the wound complications and wound problems. Take the tendon off the posterior calcaneus, remove the enthesophyte, remove the Haglund's deformity. You know, this is what you're looking at straight in the back. And you finish up with something like that. Then you debride the tendon, usually about 50% seems to be what the go-to is for most of these people. We used to do FHL transfers for all of these. You know, 10 years ago, almost everybody got an FHL transfer with this. Now it's like less than 10%, I think. And you reattach the Achilles to the calcaneus and anchors. All this stuff, why would you do an open if you could do an MIS? Look at all these studies come in the last last couple of years. Reasons I still do it open: better than 90% success rate, very straightforward. You can address whatever pathology you find through a reasonably small incision. Takes about 45, 50 minutes to do it this way. Wound complications are rare with appropriate tissue management. You gotta repair the peritoneum. You don't want to retract too forcefully, and don't take too long. No level 1 study showing the benefit of MIS for this. Again, how are you gonna clear up all this through a burr? I can't wait for somebody to show me that. How do you debride this tendon without looking at it a little bit? How do you know when you've debrided enough, and how do you repair it with appropriate tension? Whenever I ask people this, they just kind of say something like, oh, you just do it, or it's fine. And so I'd love to hear the evidence, and I'm gonna turn this over to Dr. Paramal to tell us how it works and what his experience is.
All right,
You want more, talk to me later.
that's right. Thanks, Dr. Cooper, for our introduction and then setting the stage for this Achilles tendon pathology. I'm going to talk about minimally invasive procedure, how to fix this Achilles tendon. Of course, you know, like out of fellowship, 10 years I've been doing open, right? You know, I've been doing all open. You know, everybody has you know, gone through this practice and it's all open. But I'm going to talk to you about things we can the same result can be achieved with a minimally invasive technique. I have no disclosures. This is you know, Dr. Cooper talked about what are the, you know, pain generators. The pathology to address when you have an Achilles insertional Achilles tendonitis is, you know, like Achilles tendonitis, calcification, and Haglund's deformity, right? So can we do it all with minimally invasive procedure, right? So of course, there are two things to this minimally invasive thing. One is the bone, excision of bone. Second thing is the Achilles tendon debridement. I put the Achilles tendon debridement red because, you know, like when I started doing minimally invasive, I was also very skeptic that, you know, like how are we going to debride this tendon, you know, like what tendinitis, whatever the unhealthy tissue, the distal part with the Achilles tendon. But I did some research. There are some paper about talking about, but, you know, definitely we can debride the tendon through the endoscope. What are the advantages of minimally invasive surgery? You know, decreased soft tissue dissection, potentially less pain, faster recovery, improved cosmesis, and reduced postoperative opioid use. So, you know, like Achilles tendon, you know, like don't get me wrong, open Achilles tendon we've been doing for like I've been doing for like 10 years. You know, it's a great operation. You look into it, debride the tendon, take the bony part. But if when the infection happens, skin problem happens, is a disaster because when it opens up, you're going to see the Achilles tendon, and when you see the Achilles tendon through the wound, it's never good. Disadvantages of the minimally invasive, of course, low visibility, takes more time. Cannot remove the intratendinous calcification. I put an asterisk there because, you know, there are techniques now we can use through the take the calcified part from through the scope, increase C-arm time. We need specific instruments to do this procedure, and of course the learning curve. Instruments, you know, we need burrs, instruments, continuation irrigation system to be attached to the burr handle, scope, 3.5 shaver. I use a speed bridge, MIS Achilles tendon kit from Arthrex, and a C-arm. So the key thing for this surgery is the burr, right? We now have a low speed, high torque burr. Most of the burrs are designed to operate with 6,000 RPM to minimize soft tissue damage. And it has a continuous irrigation system to mitigate the risk of necrosis. That's the console there, which has both the irrigation system and then high speed burr attached to the system. This is the MIS burrs, what we have. Basically, burrs comes into two, you know, it's a cutting burr and a shaving burr. I use a shaving burr, which is a 4.3 millimeter burr and a 30 millimeter conical wedge-shaped burr. So this is the MIS Achilles tendon speed bridge system. Basically, it has two knotless fiber tacks and two biocomposites. A biocomposite is swivel log anchor. This is the surgical technique. You know, I want to do 4 portals. And then you put the elevator to elevate the tendon from the Haglund's, and then you shave the Haglund's deformity through the portal. And then the distal portal is for the swivel log to attach the Achilles tendon. The proximal 2 portal is for the 2 fiber tacks to attach the tendon to where we excise the Haglund's deformity. And that's the ripstop, you know, we used to, you know, to protect the tendon so that the fiber tape does not cut through the Achilles tendon. And that's how we finish the case with the swivel log. So this is one of my patients, 64-year-old patient with chronic insertion of Achilles tendonitis, Haglund's deformity, and calcification of the insertion of Achilles tendon. If you see the X-ray, there's a Haglund's deformity, and then there's a big spur in the back of her heel where the Achilles tendon is attached. She's had this for 5 years, and then like multiple physical therapies, and finally it came to a point that she needed surgery. That's the position. I usually do prone position, and I usually mark the Achilles tendon, mark the portals, and mark the Haglund's excision. C-arm positioning is the key for this minimal invasive procedure. If you're a right-handed surgeon, like this patient, right foot, right-handed surgeon, you need a lot of space to use the burr. The key is the positioning of the patient as well as the C-arm, and that is the lateral on your right side. Marking the Haglund's deformity, and that's the mark. First, we mark the section of the Haglund's deformity, and that's the 4 portals. The portals are 2 o'clock portals, 5, 7, and 10. Once we do but I don't use tourniquet for this at all. And then once we do the incision, we use Prager's elevator to elevate the soft tissue, and then this is the elevator which shows right on the top of the Haglund's deformity. And then once we elevate the soft tissue, we put the burr in, 4.3 millimeter burr in, and then burr the Haglund's deformity. And once the Haglund's deformity is done, then we address the insertion part of it. This is a little bit tricky because the Achilles tendon is attached to that the spur right there. So typically what we do is, take the specialized periosteal elevator to strip the Achilles tendon from that bone. This is a little bit tricky because, once you elevate it, the part of the Achilles tendon is detached from the bone. I typically do the, Thompson's test to make sure the tendon is intact when I started off doing this, and then put the burr in and then take the insertional calcification off as well. So that's the right side. That's the postoperative C-arm chart showing the Haglund's excision, and then the insertional excision pre-op, and then the post-op. And the second part is endoscopic Achilles tendon debridement. I usually use a 2.9 millimeter scope and then 3.5 millimeter shaver, the proximal port, and then put the scope in, debride the Achilles tendon. You see that through the scope, we can excise all the unhealthy tendon, inflamed tendon. And you can see the Haglund's deformity excised, that is the Haglund's deformity right behind the scope. And once the tendon is debrided, and then we use the proximal portal to drop the knotless fiber tag suture anchors, the distal portal to do the finish the surgery. So after this, it's all suture management. The proximal fiber tag, the sutures comes through the tendon outside the portal on both the proximal medial and the lateral portal, and then that the ripstop the suture has a ripstop which cross across the tendon, and that's the the K-wire for the sole lock, and then the proximal suture, and that is we set the anchors in. And once we do this, I take the Sayer elevator to elevate the skin from the Achilles tendon, and then use a banana suture lasso to cross the suture, and then dock it distally with a sole lock. And that's how it looks. 4 incisions, and I usually close the incision with the portal stitch. Postoperative protocol: splint in the foot in plantar flexion of 15 degrees for 2 weeks, non-weight bearing. In 2 weeks, I take the sutures out, and then put him on a fixed ankle walker with 2 heel wedges, start gentle range of motion. I usually still keep them non-weight bearing for 4 weeks, but talking to the surgeons across the country, most of them, they let them weight bear in 2 weeks, but I'm a little bit, conservative on this. And 6 weeks, they can go back to regular shoes and physical therapy. Not many literature on this, but I could find one article from Japan, says good outcome, early sports activity. But these are the reference I could find on this technique. This is a pretty new technique. To summarize this MIS technique, for the correct patient and indication, definitely it's a good procedure, which can accomplish, both the tendon work as well as the bony procedure with fewer soft tissue complication. And definitely MIS technique has a steep learning curve. You should have proper training set up and understand the common pitfalls and are critical. industry innovation continues to advance surgical indication with minimized previous reported complications. Since 2000, advancement in industry, mostly the low-speed, high-torque burr, which cause minimal damage to the tendon and the soft tissue, and stronger internal fixation have popularized minimally invasive surgery in foot and ankle. Proper training and pre-operative setup is imperative for successful execution of MIS technique. Of course, like nothing is very humbling following these patients. Publication, of course, we need more publication. Basically, it's a very new technique, and yes, we can do this, with the minimally invasive technique and with good training. Thank you.
All right, good morning, everybody. My name is Caroline Tippett, and I'm the podiatrist in the group. I joined about 2.5 years ago, and I focus on optimizing outcomes and fix the diabetic foot complications. I'm from Eastern North Carolina, and my cadence can only increase but so much during this talk, but I'm going to try to finish in 10 minutes. I have really enjoyed integrating my specialty into the department. Everyone's been really supportive and have now become mentors and friends. So I want to tell you about my efforts here, and not just my efforts, but really a big team effort amongst the department and the hospital system about the limb preservation here we created at UVA. So diabetes, we all know, is a problem in the United States, is a problem in the world. We now have 38 million people in the United States with diabetes. That makes up 11% of our population. I like this chart. It's old. It was made in the year 2000. And at that time, they predicted that we would have about 20 million cases of diabetes in 2025. And we have doubled that. And that just shows you how low our predictions were and how, if not already, this will overwhelm our healthcare system. This is a heat map showing the prevalence of diabetes, and you can see majority of the dark blue dots are in the southeastern United States. And in fact, we've coined this area the diabetes belt, and it's made up of 640 counties along the southeastern United States. I don't know how Florida doesn't have more of these, but this area has 44% higher rate of major amputation than the rest of the country. Charlottesville is not one of these counties. Albemarle is not one of these counties, but we are surrounded by these, and these patients come from afar to see us every day. I'm a huge Family Guy fan, and they made this episode where Meg had bilateral gangrene and went on to amputation, and Meg then advocated to the community that she needed to improve her diet and exercise and how diabetes is bad. So I love this. I hadn't really seen this in the media before, but I'm glad that even Family Guy has caught on. Diabetes, we understand why, or we understand that diabetes causes these foot ulcers and amputation, but it's really important to understand why, and that's because the hyperglycemia causes neuropathy, causes motor neuropathy, sensory neuropathy, and autonomic neuropathy, and that sensory neuropathy is really the biggest risk factor for these complications. These people walk, they get calluses, their calluses don't just stay calluses, they break down underneath and turn into foot ulcers. And when you combine this problem with peripheral arterial disease, which 50% of these patients have, it's the perfect storm for amputation. 20% of these patients will develop one of these wounds. And we know that in 5 years after their first amputation, half of them will have a second amputation. And most of the major amputations that are non-traumatic, BKs, AKs, are preceded by these ulcers. And they have a pretty poor 5-year mortality rate, listed anywhere in the literature from 40 to 82%. And we know that they have a lot of comorbidities, a lot of end-stage renal disease and cardiac issues, but also that non-ambulatory state after these amputations is a big risk in regards to mortality. And so we all know the patients that get whittled on, they have one amputation, then a second toe amputation, and then a transmet, and then finally a BKA, which they need. And we hope that they go on to get their prosthesis and live their happy lives. But in reality, only half of these patients walk after these major amputations. And not only that, their contralateral foot is then at higher risk of developing another ulcer, Charcot, and then they become this bilateral amputee. Almost all of these patients are non-ambulatory, and 65% of them lose their ability to live independently. And so I just present all of these issues to you because it really opens your eyes to why these limb preservation teams, these multidisciplinary approaches are important. Once we get to this degree where we have an amputation, you know, there's nothing you can really do about it, but maybe we could do something on the forefront to stop the cycle. So there's been a big push amongst healthcare systems to start these teams, and it's shown shorter time to wound healing, reductions in amputation, length of stay, and healthcare costs. And so at UVA, we didn't have one of these, and we have developed that over the last 2.5 years. It's been a big effort amongst our team, the vascular surgeons, emergency medicine, internal medicine, infectious disease, and plastic surgery. And we call ourselves the Walk-On Team, the Working Alliance for Limb Conservation. And we have similar goals as the other teams in the country, and we want to improve our outcomes and reduce resource utilization. We've developed a database to track these patients. We have an undergrad student and an infectious disease fellow who's managing this database. And we hope once we get our feet on the ground to create a formal rotation for residents and fellows to train. When I was thinking of how we could execute this plan, I was thinking of how I could start small and make changes in real time. And I kind of focused on 3 separate areas that hopefully could make a difference quickly. And the first one was the inpatient side, where we created a pager, one central pager for any foot ulcers to be consulted, so we could see the consult early in admission. And this helps us get the patient to the operating room quickly. It helps us get the vascular service on board to revasc them as needed. And we've also reduced unnecessary admissions through creating a reliable way for the emergency room to send these patients into the office. And this is for those subacute or chronic type of patients who don't necessarily need admission. We've opened up office visits, and we have been approved to create a wound care center at Zions Crossroads to open up even more slots and provider spaces for these outpatient referrals. And then lastly, focusing on a prevention/remission clinic is something that I don't feel I've been very successful for, but something that's very important. These high-risk patients, the patients with full-blown neuropathy, deformity, or amputation really need to be seen every 3 months. And this way, we can keep an eye on them. We can offload them with the correct shoes. Their calluses need to be shaved down so they don't turn into ulcers. And we can even catch them and do surgery on them, like Achilles tendon lengthenings or flexor tenotomies to reduce those biomechanical pressure points. This isn't a glamorous job, and it doesn't reimburse well, and really no one wants to do it. So sometimes I feel like I'm carrying the weight of the world on my shoulders because we have all these patients and no providers to help with this. But this really is going to be the only way that we can stop this cycle. We created an algorithm to triage foot ulcers in the emergency room. And this is kind of an eyesore, I apologize, but we have broken down wounds into mild, moderate, and severe, and then emergent, and who to consult and who should admit, making all these recommendations for the emergency room. And then also who is safe to discharge and how they can reliably get into the clinic. Our infectious disease team came up with a very simple antibiotic regimen for antimicrobial stewardship and uniformity amongst antibiotic prescriptions. Since we've implemented this in June of last year, we have had a reduction in the length of stay by 1 day from 7 to 6 days, which is just really long still, but at least we've had 1 day reduction. We've had a significant increase in limb preservation pager consults. And one thing we're still working on is reducing the median length of stay in the emergency room. And that's really important to us so we can free up some bed space and unclog the ER. And lastly, we have a community outreach initiative. We got a grant to hold foot screening and education sessions for patients in Nelson County. Nelson County is just southwest of Charlottesville, and it's pretty underserved and rural. And another part of this is going to be to educate the primary care doctors in the region. So hopefully they can kind of be our eyes, develop these relationships for timely referrals, and perform routine foot care and wound care. Thank you so much. This is Eddie, who is our last graduating fellow, and my wonderful team. Please reach out if you have any questions. Thank you.
I think Carolyn downplays the importance of what she's doing for our department and for our community and for our region. I mean, we are overwhelmed with diabetic patients, but limb salvage patients. Dr. Hurwitz was doing this all by himself when he was here, but she's developed. It is a team, sure, but she's single-handedly done this. Hard to get vascular and general surgery and ID and medicine involved, but she's done a remarkable job in 2.5 years. But 1 day loss of length of stay reduction for the medical center is tens of millions of dollars. Tens of millions of dollars, because they'll fill it with another patient that will generate revenue. So you are you're doing tremendous things, and we'll just keep doing what we can to support you. Thanks so much.
So last division is the trauma division, oncology division. I just want to say that I was a resident here from 2007 to 2012. So I got to experience the transition between not having a trauma service and having a trauma service. I think one of the best things that happened to our department was bringing Dr. Dave Weiss in back in 2009, 2008, 2009, 2010, who basically took us from having the trauma room was wherever today was available. You're basically scrounging to get cases done. And now we got a full-fledged trauma service that basically runs the show here under Dr. Weiss's, under his leadership. It's been really wonderful. So we're going to have Dr. Weiss talk and finish up the program. Thank you.
All right, thanks everyone. As I always say, save the best for last. So I'm going to talk briefly, just to give an introduction on the trauma division, then I'll give a brief talk about some of the things that we're doing in education. Then Dr. Heat's going to tell us about some of our international outreach programs, and Dr. Yarbrough is going to finish up talking about some novel treatments for ankle injuries, and then Dr. Seaman and I are going to have a debate to finish up the conference. So this is the trauma and oncology division. So as Dr. Quattro mentioned, I came back in 2010. Dr. Yarbrough joined us in 2012. Dr. Hadid was one of our residents here and came back and joined us in 21, and then Huggard in 23. And then Thompson is off in the corner. He still hangs around once a week for the oncology portion. But we've been successful in making sure that the trauma room runs efficiently and that we can handle inpatient consults as well as outpatient things. We have 3 APPs who work with us. Jackie Wilson is one of our PAs. Claire McMahon joined us 2.5 years ago as a nurse practitioner. She's out on maternity leave right now, having her first baby, but she's doing a great job. She helps with the oncology division as well as the trauma division. And then Laura Myers joined us about 1.5 years ago, and she helps with some of our trauma things and also our fragility fracture clinic. And so we hired Laura with the idea that many of the patients that we were seeing in patients who had hip fractures, as well as many patients who were being seen in other clinics, maybe with distal radius fractures or spine compression type injuries, or other types of insufficiency fractures, were being treated for their orthopedic injury, but weren't really getting treated for their bone health. So we established this clinic so that there'd be a referral source. So basically, we set it up so that all patients over the age of 50 who had a ground level fall and sustained a fracture would then generate a referral to this clinic so that they could be evaluated for their bone health. Everybody who's a hip fracture or fragility fracture in the hospital gets operated on, gets an automatic referral as well. We were sending them to the endocrinology service. They were getting overwhelmed. They were, patients weren't being seen for months and months and months. And so this rapidly improved the efficiency of seeing these patients in the both in the postoperative period as well as for evaluations for any type of osteoporosis. And we now get referrals from the endocrinology division, who's so busy they can't see routine osteoporosis referrals. They send them over to the fragility clinic. And this is also great for patients who are being evaluated for elective procedures like in the spine clinic. And they said, oh yeah, we can, you need a correction and a fusion, but your bone density is kind of low. And so they'll get sent to the fragility clinic and they'll get on medication to increase their bone density. So in 6 months or a year, they can have an elective type spine procedure. So Laura's been a great resource for that. And then we just started about a month ago, we started an orthopedic walk-in injury clinic that started as an after-hours clinic that's currently open between 5 and 8:30 on Mondays to Thursday and 9 to 12:30 on Saturday. If you walked out in the lobby today, you saw some people milling around at the desk, and that's our walk-in clinic for Saturday morning. And so we can see walk-in or same-day appointments for orthopedic injuries. Cassie Casper, who's pictured here, is starting at the end of this month. She's going to be the PA staff in that clinic full-time. But we have people currently, our current APP staff or physician staff are staffing it currently, and it's been very successful. We've been open just over a month, and each week we've seen an increase in patient volumes, and it's been a much easier way. Every Monday morning or Tuesday morning, almost anybody in this room, probably wherever you practice, you get phone calls. Oh, Billy hurt his ankle over the weekend playing soccer. Can he be seen? So-and-so's got a knee injury. This athlete needs to be seen. Or you're in clinic, it's 4 o'clock. Someone's got a wound problem. Can it wait till tomorrow or the next day? Do they need to be seen right now? And now we have an opportunity for these patients to just be seen and evaluated without having to go to the emergency room. So we've stopped a lot of unnecessary ER visits and increased a lot of patient satisfaction.
Can I comment on this? So this is Dr. Weiss's effort for almost 7, 8 years. So we finally got approval to get this open, and we're the only one in the area that has this. And waiting 6 hours in the ER to get an X-ray, ankle boot is just in a $3,000 bill is not acceptable anymore. So this is a clinic charge, so it's very beneficial from a cost standpoint for patients. And we capture all these patients because once they're seen here, and if they need an MRI, it gets scheduled and follow-up is scheduled with the specialty team. So I'm hoping to expand market share to a point where no other orthopedist can survive in Charlottesville and surrounding. You guys know how competitive I am, so I want to shut everyone else down. But this clinic, I mean, we're seeing 10 to 15 people every night now, every day. It's really getting very busy. So, and we're sort of generating surgical cases out of it as well. So I think it's going to be extraordinarily successful. We haven't really even done the full-blown marketing, so we'll see.
So I thought I would go into now just a quick talk about some of the things that we're doing on the education front, just some interesting things, so maybe some new technology that we're exploring on the education front. Just as a disclosure, I'm going to be talking about a company that we work with, or that I work with, that we're using here, that I do have some stock options in or ownership in, so that there is a disclosure. This is not a commercial thing. We're just talking about the research that we're doing with this company, but just so everyone's aware. So what's new in ortho education? So simulation is kind of been the buzzword for the last 10 years. The ABOS began a program in 2013. Just a quick show of hands for those of you who are not part of UVA currently, who works with residents or resident education or has some interaction there. Yeah, so so the ABOS in 2013 said simulation is really strongly recommended for practice, because basically they were concerned that people aren't getting enough time in the OR. The OR is maybe not the best place to learn new skills. And then, as we've sort of expanded our reach in orthopedics, it's not the classic, where the orthopedic residents look different, and maybe not everybody's had the chance to develop skills, hand coordination skills, or skills using tools or things like that. So the thought was, hey, the best place maybe to learn this isn't in the OR, which is valuable, and we're getting more and more pressed for time. So how can we sort of practice these things? And they came up with these modules, many of which were either sawbones or model-based. And I know Dr. Hurwitz was part of the board when they were developing some of these things. And so this is just a quick overview of the modules. We're not going to go through each one, obviously, but if you go to the ABOS website, if you're interested, you can see some of these different things. There's 17 different modules, and each one has some specific tasks, some recommended skills, and things like that. So this was an excellent first step as far as saying, hey, we think there's a skill set that people should have, and these are some of these skill sets, and here's kind of what we recommend, and here's some options for doing them. So but again, many of these are kind of sawbones based or model based or cadaver based, and those things are kind of expensive. They're, once you use them, you got to keep supplying them and things. So what are some options for practice that maybe can address this in a little different thing? So virtual reality was the next phase. This started off with companies that develop these virtual reality systems, and they really started in industry. Companies were developing tools for industry, and it was essentially helping to train the reps, but also to train the surgeons who were learning new techniques. And so if you were going to switch to a new reverse total shoulder arthroplasty system, you could then, instead of just looking through a technique guide or maybe going to a course, which you might still do. Now you had this sort of virtual training opportunity where you could walk through the procedure and practice this, and it would sort of score you along the way. Hey, the guide's supposed to be in at this angle and you're putting it in, 5 degrees off, do this instead. Or, this step is really critical and make sure that you've, verified this before you move on to the next step. So it's much more interactive, and the systems were getting better and better as far as tactile sense, as far as stereotactic feedback. So this is just an example. We had our interns using this a few years ago. Vibe, with your class, I think you were the first class that we did it with the interns, where we had diffuse synthase setups. And this is the now Johnson & Johnson MedTech. We were working through some of their different modules on putting in a tibial nail or putting in a hip nail or something like that. So there were different setups for that. But there were some limitations, right? So if you were using the Johnson & Johnson system, you learned how to use the Synthes nail, but you didn't necessarily learn the techniques of putting a nail. You learned how to put in a Synthes nail. You learned the steps of that. So it's a little bit mechanistic, but it certainly was helpful in sort of showing you some trips. So we moved on to the next level. So this is a company called Osso VR, and they developed training systems. They were actually developing a lot of these modules, and they realized that, hey, maybe these would be good for resident training too. And so they developed, this is kind of a resident training and student tool. And so they have all these different modules, training modules to practice different procedures. So, and the modules are interesting because they're not just about the procedures. They're sometimes they're not just about the performing the operation. It's actually all the steps of the operation. So for instance, I've been through some of the modules like in the spine module. And so they're like, you're doing an X lift for the spine. So first you have to position the patient on the table. They have like a virtual table, and you've got to like position the patient properly. If you don't do it properly, it's like, no, you need to have a bolster here. You have to have the patient in this position. So it kind of goes through a lot of these different steps. It's really not just about the mechanics of putting in a screw or what you have to do with that. So it's a little bit more holistic, a little bit more complete for this. And so it has some value in that area. So what are the pros of virtual reality? Certainly you can get multiple rounds of practice. So you can do the same thing again. You can practice it a bunch of times, and you can get scored on it. You don't need any specimens or sawbones. So once you paid for the system, there's really no cost to use the system. There's options for testing and performance metrics. So you can go through a module and practice, and then you can set, okay, now how long does it take me to go through, or what am I, how accurate am I in doing this particular thing, if accuracy is the thing, and then you can measure it against other people in your residency, or potentially have the experts do it and sort of establish the benchmark, and then you can sort of see how you do it against the expert testing. It can be done anywhere you have an internet connection. So you can take this and go home and do it at home. You can collaborate, so people can be in one, 3 different people can have a headset at their different houses, and you can connect together so that you're all in the same virtual room, even though you're not physically together. So it can be easier to schedule when people are in different places or different coordination. And the current simulations are fairly advanced. When you pick up a drill, it feels like you have something in your hand. When you pull the trigger, it makes a noise, and your hand kind of buzzes. So they use these controllers that you saw in that picture, in that first picture, like this. You have a controller in each hand, and you've got a headset on, and it's like an Oculus style headset. So it's pretty, it's fairly realistic. It's pretty interesting. If any of you are interested, we have some of the headsets here. I can talk to you about it afterwards. So the cons. So although it still feels good, it's not like holding a real instrument. It's hard to position your hand. Just, a lot of orthopedics is about feel. And although the feel is better, it's still not the same as the real thing. They are moderately expensive. The system can cost money. The headsets are actually fairly cheap, but the software obviously is expensive, and then you got to update it periodically. It can be a little bit like playing a video game. Just like if you play a video game and you learn the moves and you learn the different things, you can get through the levels, and then you're like, okay, I mastered the game, but do you really understand what you're doing, or did you just kind of get the game? So once you learn the moves, you can win. Is that the best thing? A lot of these modules are fixed. So, you go through the module, but it's kind of the same each time, right? If you're fixing a distal radius, it's the same distal radius. You're not really allowing real cases, although some of the systems are changing for that. And we have one of the systems that's allowing some preoperative planning, but the practice ones still need to be able to introduce it would be nice if you could introduce your own case, so you could fix a distal radius that you're about to fix either later that day or the next day, or that it's on the schedule, instead of fixing the model distal radius. And we still really haven't integrated into the curriculum. We're trying to figure out how to get it into part of training. We're trying to encourage people to do it, but it's still not quite, it still doesn't feel like it's a natural part of the residency. It still feels like just an experiment. So now, moving on from that, we also have a system. So we have a system that does training. We also have a system that does planning. And this allows actually real case-based planning. So you can take a CT scan and you can upload it into this virtual world. And you can construct and deconstruct images. The computer segments out, we're using it for fractures. And so the computer segments out the fractures for you. And you can take the fracture apart, you can put it back together, you can look at it from all angles. and you can add hardware, and it uses the Oculus headset. And so this is just an example here. This is me manipulating an ankle fracture. I'm just going to show you parts of this video. This is what it looks like. You're in this virtual room. You can kind of move around. You can see this fracture. It's a bimal fracture. It's actually a trimal fracture. It's been segmented into the different parts. We're manipulating the lateral malleolus now. And we're moving this around just with a hand controller, similar setup to what I showed you there, the Oculus and the hand controllers. And then you can, and what I've done is I pulled the foot down so you can see more of the fracture work. And then you can see here on the back wall, you can adjust the various transparency or the colors of the things. So those are some menus. If you look, if I were to look further to the right, you could select some different menus. If you wanted to make the pieces brighter or darker or different colors or make them more or less transparent, you can do that. And then, so we kind of manipulate this piece. I'm just going to run this ahead a little bit. And so we've manipulated this piece, and now we've kind of got it set. And I'm selecting now you can see on the left wall there are as another set of menus, and we can select like plate options, screw options. We can select some different things to actually now start sort of building our preoperative template. So here I've selected a plate. It comes into view. And now I'm manipulating the plate. So, it comes in one position. So we're manipulating around, and we're kind of just now adjusting it. We're going to put it on the patient. And so we're essentially going to end up with a preoperative template where you can help with that preoperative planning. So it's fairly, I'll just run this ahead to here. So we're selecting some different parts of it, and we can, set the plate on there and select some different screws. So it's kind of an interesting option for sort of three-dimensional preoperative planning. And then if I want, I can record that as a video. And so I can say, hey, here's how I would put this fracture together. And then if a learner wants to do the same thing, and then they can look at how I did it, and they can look at how they do it. So there's a nice way to sort of have sort of a, expert opinion in basically, or we can do it together. We can be in the same room, virtual room, and do that. So this is then the next step after that. So that's cool. And it's interesting. You're in the virtual planning, but now we're going to talk about augmented reality. And so here we can have where you can do some of your planning, and you can actually transfer it to the operating room. And so this is a Microsoft HoloLens, and this is a thing, I think Bayan showed a picture of this earlier, doing some in the spine world. And so you can see, on the left, your goggles are down. Now you're looking through this lens. It's sort of like looking through a pair of light gray sunglasses. But if you don't want to have that in front of you, you can flip it up and just have your regular, vision looking ahead. You can kind of see you can see this sort of projector, the lenses that are projected up in there. And so this is an example of what this might look like if you were doing this. We did this down in the cadaver lab. You can see an image that we've taken. I narrated this a little bit. Play this for just about 30 seconds. You can see I'm manipulating this with hand motions now. We also have a sterile controller. We've taken this from the virtual world, and we're now moving into the real world, and you can actually do this in theory in the operating room. We haven't done any cases with this yet, but that's kind of the next step. And so you can see that we've taken that from the virtual world and we moved it into the real world. And you can actually have that image in the operating room. So it could be sitting like off to the side. And so you could be doing your case, you could look right over there, or you could move something. And currently working on networking so that you'd have two people with them in the same room and looking at the same thing, and sort of in the operating room, kind of being able to draw on the model and then having a real life thing in front of you. So kind of removing that technology into the real world. So in summary, simulation is playing a larger role. New technology is more realistic and allows for multiple iterations, and it's interactive and allows some personalization, but it's still not a replication for the real thing. Thanks.
How hard is it to use this? I mean, it's a little painful.
It depends on your age. Yeah, right. Actually, yeah. So I would not call myself a young technology adjacent person, but it's actually not. It's surprisingly. The hard part is when you first put it on, you've got a little bit of training to just practice like using your fingers and things like that. it's not perfect. Like you go to grab something and it's sort of like not quite right there. It's, you know, and you have to move it around, you have to play around with it a little bit. So you have to recognize some limitations with that, but it's actually not bad. And it's actually easier to work with a controller. There's like basically a Game Boy or a PlayStation controller that you put in a sterile bag. You can manipulate it fairly easy with the controller. But the neat thing is, as you saw, you can make multiple copies of things. So I have a copy that's like my injury copy, and then I have a copy of like the replicated, reassembled copy. So you can make 3 copies if you want, looking from different angles. You can look at a copy that's a sagittal with coronal. So you have the ability to sort of look at things from all different angles. So I think it has some interesting potential.
All right, so I'm Michael Hadid. I did residency here until 2020 and then back on faculty for the last couple of years. And so I was going to take just a few minutes to talk about some of the international work at UVA. So we'll keep it short, sweet, most of the pictures. Talk about some recent past, kind of the organic growth of international work, and then present, and then into the future. And so recent past, 2017 is kind of the beginning of it. Dr. Chava went with the Touching Hands organization through the ASSH to Honduras for 1-week mission trips, and see a bunch of people on the first day you're there, stack up a bunch of surgeries, get a bunch of surgeries done. So he's gone back a couple times in the intervening years. In 2019, first time recently that residents have gone. So I went with Dr. Dacus and Victor, who was here yesterday, to a town in Guatemala. And as you see there, so when you show up, it really is just a line of people waiting to be seen. And so word is put out in the villages surrounding area that people are coming to, do medical care. And so people will just line up, and they went around the block a few times and then down the street. And so they're just there waiting, hoping to get someone to see them and check them out for all sorts of things. Some of the pathology that we saw during that trip, pseudoarthrosis, the tibia, club feet, pretty severe stuff that really can limit the basic function of these folks. A lot of these areas are very walking dependent, and so you need to be able to get around. And so people with these issues are severely limited. It's often it can be different than here in the States. You're working in hallways, got a couple different OR tables in the same OR room, but trying to do the most with what you have available. Also having a little bit of fun, says all 3 of us in that little tuk-tuk. And then I don't know what I was thinking when I took that picture of us wandering the streets at night. I don't know if it was like recording events, so when they found our bodies, they would be able to piece it all together, but try to have a little bit of fun too. In 23, Aaron Frulich went to Kenya, I think for an extended week, 10 days, something like that. And here, I think you can see some of the similarities. So talk about some of the differences, working in limited resources, but also, you still round on patients as a team. You have an OR setup that's really largely similar to what we would have here in the States. You might have some interesting surgical instruments like that axe in the center, hatchet maybe. And then James Brown went to Honduras, I think it was 24, and similar to Charlottesville, people lining up for their knee replacements, and he was there to knock them out. And then I went back to Guatemala in 24. At this point, I was attending, took Alyssa, who's here in the room, and then Katie Kraus, one of the nurses in the OR, went through an organization called Faith in Practice, and it showed the kind of different setups that you can have, largely based on these organizations that have grown throughout the years. This one, a little bit fancier accommodations. When Dacus, Victor, and I were there, the room we stayed in, it was all 3 of us, and we stayed in a room about the size of us. There wasn't much more. This was a shot from where we ate all of our meals at this trip in Antigua. Those are 2 volcanoes in the background that would puff out smoke, and at nighttime you could see a little bit of flames. But again, very kind of severe pathology that you're dealing with. This case, fortunately, wasn't infected, but I think I did more infected non-unions that week than I did in the year prior here at UVA. And sometimes you got to just fill in random roles. And so X-ray tech some of the times, IV pull some of the times, whatever it takes to get the job done. And then recently, just this year, Dave Weiss went to Tanzania with the Surgeries Overseas Assistance Program started by a guy down in Charlotte. And I think kind of a more unique aspect to this trip is that there's a lot more education involved. And so that was just a daily morning conference and anatomy lab they did while they were there. And then Dave Weiss and Jason Halverson, who's at Wake Forest, leading residents through surgeries. And so the Wake residents do international work and they go for a month to Tanzania. And so it's just kind of where we've been. So a couple times to Guatemala, many times to Honduras, and then, Eastern Africa. So I think some of the lessons, it takes a team. You really need a lot of different things to go right, a lot of coordination to have any kind of successful surgery. Standard work eases integration. It's amazing combining with people from all across different places that they train, different places that they work. It really works the same in a lot of ways. Pathology is very dramatic. It's really severe disease that you're going to see and be able to treat and help. And creativity and planning are critical because of that. You have limited resources, but you're dealing with some of the worst stuff. So you really have to be thoughtful and plan things out carefully. I think there's a lot to learn from local providers. When you think about this, a lot of times it's like you're being dropped in like a hero to come save the day, but I don't think it's that way at all. I think there's a lot of bilateral learning that can go on. Follow-up is still critical. And so I think getting involved with organizations with people that have a consistent, sustained presence. And so you're not just coming doing a surgery and then these people are left to deal with the consequences if there are negative ones, which there can be. Patients are remarkably appreciative. They don't complain. It really changes their lives. They don't have access to narcotics and things like that. And it's not a problem, which is kind of nice to see sometimes. Overall, it's kind of humbling. It's very satisfying. It's pretty fun. I think when you are down there, everyone's together. It's not like the nurses have one agenda, the doctors have one agenda. Everyone is aligned and everyone's working together, which is kind of nice and refreshing sometimes. So that brings us to present. And so Stan Gilbert is here in the audience. Raise your hand. And so, please, yes. He contributed a significant amount of money to start this Gilbert Family Global Health Orthopedic Fund, which is an endowment. He went to UVA Medicine, and then he was in the Army for residency in his early career, and then did general orthopedics in Fayetteville for 35 years. When he was in the Army Reserves, he went to Desert Storm for 5 months, and then came back interested in volunteer work, went to Bolivia with a colleague. That really became a recurring trip with his wife, who learned to assist with him in the OR. And so this fund provides for annual global health experiences for residents in resource-limited locations throughout the world, which is really amazing. I'm part of the International Program Council, and I go to their meetings sometimes, and funding is one of the biggest limitations for getting people to do this work and go on these trips. And so to have that taken care of is really unbelievable. And so then now I'm in charge of trying to figure out how to get our residents this experience. And so when polled, 100% of residents were interested in an international orthopedic elective. And there was somewhat of a dichotomy, people interested in a kind of a 1 week service oriented trip versus a longer trip with education from local providers. And some variability between 2 and 4 weeks, what the ideal trip length is. Talking with other programs that have kind of robust international electives, really the longer you're there, the more you get out of it. And so a lot of people that I've talked to that have set these up, that have feedback from years from residents, they say really 4 weeks and even beyond that is very valuable. And then this was of the attendings here who would be interested. So about 2/3 interested in going on these trips. And so the goal is to develop both 1 week service oriented trips and then 2 to 4 weeks trips that incorporate more of an educational component. So hopefully we'll have an opportunity for all residents. And then I think this could be an opportunity for alumni to participate as well. And so if you're interested in this kind of thing, shoot me an email and I'll keep you on a list. And then I think this will really get up and running over the next 18 months. The volume will pick up and might be an opportunity just to be engaged with the program, get to work with residents if you don't normally, that kind of thing. So something like that.
We're starting this endowment. It's going to really help with recruitment, I think, for our residency program. Mike Redler, one of our alums who I think is here right now, he goes to Honduras every year, and he took Mark Miller just a few months ago, and they had an amazing experience. So that's another potential site. Mike, I need to connect you with. We hope to give the option and the Gilbert Family Global Initiative
and fund to help us support family and residents with the interest to go abroad and serve. So it's a really excited about it. So, and thanks to Mike for doing all this.
All right. 10 minutes, 9 minutes for the last 3 talks. So arthrodesis for ankle fractures, debates 2. Yeah, so we'll talk about the when and how of ankle arthrodesis. Some of it's fairly straightforward. This could be a much longer talk, but I may go a little over 3 minutes. But so debate, what literature do we have? This systematic review says things like yields reasonable results can be used, current lack of literature. So not going to be able to lean on the established literature to understand how to use ankle arthroplasty. Some of the easy stuff, destroyed joint, Charcot neuropathic joints, chronic injuries, things like this. So this is a 47-year-old lady, diabetic neuropathy, who was treated in a cast. Wasn't terribly happy. Hindfoot nail, that's a pretty straightforward indication. We can talk a little bit of technique as time allows, but just to get through the win. Victor Anciano wrote this up when he was a resident. Pilon non-union, instead of trying to put those giblets back together and get the bone to heal, is just somewhat ignore them, bypass them, bone graft aggressively, prep the joints, and even if you get partial healing there, we had a couple of patients, I think 3 in the series, who did well. It's just another example of that, where the CT scan, which I don't have here, showed a substantial amount of non-union across mostly the anterolateral side. Same approach is good fixation of the bone above, prep the joint, solid fusion mass. The gray zone indications, these patients are neuropathic but don't have a destroyed joint, have a really high BMI, and you just don't trust the fixation, maybe a little bit of both. Two often go hand in hand. Open fracture infection, severe Pilon. Show some examples. This is sort of the destroyed example. 57-year-old female, got into a frame that looks a little better in terms of the talus' position in the world. But the CT scan, you're going to put all those back together. You're just better at that surgery than I am. We could probably make it look like a joint, give a curve above the talus, but in terms of expectations, that being able to heal without debilitating arthritis, I'm not so sure. So the approach, long plate, obviously, but then for the ankle specific part, prep the joint, incorporated those fragments best we could, bone grafted pretty aggressively, and that patient went on to successful union. So a couple of slides on the how. Open ankle arthrodesis, I would prefer to use compression screws and a plate, just for the durability of it. These patients are often going to put some weight on it early. I think you can be successful with screws only, arthroscopic. There are options. This is how I would do it. Incision placement can be flexible. A lot of times you got soft tissue concerns from their previous surgery, from their previous injury. So anterior, anteromedial, anterolateral can all be options. Foot and ankle folks like anterior because it's a nice position for future ankle arthroplasty needs. I try to be thoughtful about that before dismissing it and then go ahead and doing the anteromedial approach. 92-year-old lady this is initial injury film. So this is an example maybe of not reconstructible, but what did we do? Here 5 weeks post-injury. Okay, I don't know, doing okay, but not doing okay. So the lateral shows talus is dislocated posteriorly. So 6 weeks, which happened to be the first clinic visit with me, all these others outside hospital management, see the patient back there. And just based on time frame, functional goals, concerns for joint condition, didn't even get a CT scan, just went on to a ankle arthrodesis. So that was through anterior approach and plate with compression screw goes in first. Couple quick points, just being really diligent about talus position. You really want to match that alignment of the tibia for appropriate coronal plane alignment. You can position the screw. So if there's a tendency for valgus, for example, have that screw on the medial side of the talar body to induce some varus as you compress, and then neutralize that with a plate. You can flat cut the top of the talus. If there's remaining bone available, certainly maintain some contour, debleeding subchondral bone on both the tibia and talus side and have some congruity there that can be helpful. 3 months, she was solid, never saw her again. I don't think that'd be the case if we tried to put that joint back together. Spare the subtalar joint must be a good thing, sort of like the parachute argument. I don't know, more native joints there must be good. But sort of the nervous smile of, well, but the literature doesn't really show that. Those patients are going to go on to subtalar arthritis. Important to
counseled them on that. And there is a very typical compensatory motion, varus pull of the gastrocs. So they end up with a stiff arthritic subtalar joint that is likely going to be a problem later. So if you need to do a hindfoot fusion nail, do the hindfoot fusion nail. Probably not as big a deal as I would have imagined. Thinking about it, I'd still say, we'll talk about on the summary slides, preserve any native joint that you can. We'll do the fibula for an ankle arthrodesis like we showed, ignore, cut it off, incorporate it into the fusion, butterfly it and screw it down, just excise it. Leaving it long is probably not a great option. This is a patient who had been fibulas fixed at the time of the pilon surgery, went back to do the arthrodesis and didn't mess with the fibula, but he hated it and cut it off and he loves it. So he had shoe wear issues. We sort of talked about, we could do a shortening osteotomy, whatever. He said, I just want the most straightforward option that lets my foot fit in my boot as well as possible. And so, I think he was stiff and stable enough that that was a reasonable option for him. A couple of technical points for hindfoot nail. This is just talking about trying to avoid stupidity, Charlie Munger quote, instead of trying to be extremely intelligent. It's probably a better approach just to avoid mistakes. So technical points for that. You want to avoid excessive varus. For a straight nail, it can be a tendency to put the foot in varus to get better bone path through the calcaneus, but that's going to lock transverse tarsal joints, make the foot even more rigid for joints that you'd like to maintain some motion. Avoid plantar flexion, so it's the path of that initial guide wire, just like whether you're doing subtroch femurs or proximal third tibias, you really got to be diligent about that wire path, because that's going to dictate the position of the foot as the proximal part of the nail just engages in the diaphysis. And then avoid internal rotation. You really can't roll through. Always make the point to residents, if you put somebody in a short leg cast that's locked at 90 degrees, how do they walk? As they externally rotate and they roll through. Well, if you've taken somebody's native limb, internally rotated, it makes it much harder to walk, especially given the rigidity they're going to have from that hind foot. 2 minutes on, oh man, I'm past the 3. 2 minutes on ring fixator. Good options for infection, soft tissue compromise, or patients who are going to walk on it. This is an example outside surgery, 58-year-old moderate neuropathy, BMI 38, came in. This is post-op day 1 images. They put a gauze on that and sent her to clinic. So we're like looking at the hardware clinic and talking about it. So she went on, did a ring fixer. Sorry, I didn't wipe the blood off. I didn't know it was going to be a talk at that time. But prepped the joints, compressed with the frame. There's no free passes. Dr. Dunsing, I don't think, is here. He fixed this on the weekend, so slipped and fell. There's strategies we talk about in a longer talk about oblique pins or offsetting those or not using 2 pins in the top ring. But ultimately, it's not a beautiful fusion site like you might get with an open arthrodesis. Maybe it looks a little more spot welded, but this is over a long time frame that she had done well, and saw her back in longer term follow-up, make sure that wasn't going to fall apart. And she had done well. So that's kind of some of the technical points from frame. Ankle arthrodesis is useful, more than just salvage situations where they've already failed. It can be used as a primary approach. Plate, nail, and frame can all have their benefits and be used effectively. It's level 5 evidence, but spare the subtalar joint when you can, especially in younger patients, and important to counsel them on subtalar arthritis. Thank you.